Today, the Healthcare Subcommittee is taking an important step in reauthorizing critical programs within the Health Resources and Services Administration. The policies before us today each play a unique role in providing greater access to care for millions of Americans, particularly those in rural and underserved communities. Many of these programs expire on September 30th. By taking early action, we are providing reassurance that they can continue without disruption. Early action also provides subcommittee members with the chance to review the impact of the policies are currently having and ensure all future funds are directed in the most effective and appropriate way possible. It also gives us time to work together and find bipartisan offsets for mandatory spending in future years. The first bill, the Strengthening Community Care Act of 2023, would extend the Community Health Care Fund and the National Health Service Corps through 2028. Both programs allow millions of Americans across the country in medically underserved communities to receive access to high-quality primary care services, including pharmacy, mental health, substance use disorder, and dental care services. Across Kentucky, HRSA's Uniform Data System data shows that 25 health systems received grant funding in 2021. Nearly 600,000 patients were served, many of which were served by providers who participated in the National Health Service Corps. I want to thank Dr. Joyce for leading on this important issue, especially at a time in which we are facing primary care provider shortages across the nation. I am hopeful we can come to a bipartisan agreement on a path forward to extend funding and on the necessary offsets for the Teaching Healthcare Center graduate medical education program. I am committed to working with my colleagues to continue these essential programs. However, I do think we should not make these programs permanent at this time. We're examining the National Nursing Workforce Center Act led by Representatives Kim and Blunt-Rochester. This bill is designed to help bolster our nursing workforce and would specifically require HRSA to work with state nursing workforce centers to help streamline their nursing workforce programs. This would ultimately provide more targeted investments that reflect the need of local communities. I thank my colleagues for working on this bipartisan bill. I also would like to thank Representative Blunt-Rochester for working with me on one of my nursing workforce priorities, the Building America's Healthcare Workforce Act. This would address very serious nursing workforce shortages in the long-term care community. I will continue my push to advance legislation like this that cuts red tape, especially as we near the expiration of the COVID-19 public health emergency on May the 11th. We will also consider proposals to provide continued access to key programs for chronic conditions such as diabetes. The Special Diabetes Program Reauthorization Act of 2023 and the Special Diabetes Program for Indians Reauthorization Act will provide continued funding for both programs through 2028. Over 1.6 million Americans living with type 1 diabetes, these programs will allow patients to continue receiving comprehensive diabetes care and will lead to a higher quality of life and lower healthcare costs for patients. I thank Representatives Bilirakis and Cole for leading on these issues. We're also considering legislation that will promote more transparency and greater access to care for over 100,000 individuals in need of an organ transplant. Dr. Bouchon's Securing the U.S. Organ Procurement and Transplantation Network Act would ensure the nation's organ procurement system is operating more efficiently, which will ultimately lead to greater access to organ transplants for vulnerable populations. Lastly, we're examining a proposal to increase transparency within the Covered Countermeasures Injury Compensation Program to help ensure claimants are receiving adequate information in a timely manner. I look forward to today's discussion. I thank the witness for being here, for being with us today, and I yield back. The chair now recognizes my good friend from California, the ranking member of the subcommittee, Ranking Member Eshoo, for 5 minutes for an opening statement.
Thank you, Mr. Chairman, and good morning, Administrator Johnson. Welcome back to the Health Subcommittee, and thank you for your superb leadership at the helm of the Health Resources and Services Administration, overseeing more than 90 programs that improve the health and well-being of all Americans. You head up the agency with grant making, and it's the dispersal of those funds in HHS that really make the policies dance. So thank you. Today, our subcommittee is considering 8 bills to extend critical public health programs, bolster the health workforce, and address the broken organ transplant system. We're going to hear testimony about 5 health programs that expire on September 30th, community health centers that are really core operations in our congressional districts, the National Health Service Corps, the Teaching Health Center Graduate Medical Education Program, the Special Diabetes Program, and the Special Diabetes Program for Indians. First, we're considering a bipartisan bill to extend mandatory funding for community health centers and the National Health Service Corps for 5 years. The Community Health Center Fund provides support to nearly 14,000 health center locations across our country. These health centers provide primary care to 1 in every 11 Americans. We cannot do without them, including 1 in 5 Californians, regardless of their ability to pay. A community health center in my district, the Asian Americans for Community Involvement, provides a full spectrum of care through a multilingual team of doctors, nurses, and patient navigators. They've earned a superb reputation for the care that they give to people in the community. And at this health center, the team can speak more than 40 languages to ensure their services are responsive to cultural beliefs, to practices, and preferred languages. The National Health Service Corps is a highly effective program that's been connecting providers to patients in need for over 5 decades. I'm disappointed that funding for these programs is not adjusted for inflation, despite the clear need, but I support the bipartisan reauthorization. We're also considering programs to improve access to primary care. We have to stay on this because that's the entrance to the entire healthcare system in our country, including the Teaching Health Center GME program and the Special Diabetes programs. They support viable primary care workforce for low-income communities by providing residency, and we spoke about this on the phone, residency training at federally qualified health centers. The Affordable Care Act enabled the teaching health centers. Can we not talk in the background here? It's distracting, please. The Affordable Care Act enabled teaching health centers to train residents. 13 years later, these centers have proven they can successfully train residents who will build their practices in rural and underserved urban communities. This is, a giant bravo on this because it really is working. But funding for this program remains elusive and inconsistent, preventing it from reaching its potential. I support the legislation we're considering today to permanently authorize the THCGME program and fund new training sites to increase resident physician spots, and I believe that this subcommittee can get to a bipartisan agreement on this reauthorization. The other expiring programs include Special Diabetes and the Special Diabetes Program for Indians, which provide critical investments in research and care for those living with diabetes. I have more to say, and I'll say it as we move through our hearing today because my time is almost up. But I want to thank you for your leadership, and I want to thank you also for sending out to each one of us HRSA in our congressional districts, because this really brings it home about what HRSA is doing, the grant making, and the difference that it's making in the lives of our constituents. So with that, Mr. Chairman, thank you for holding the hearing, and I yield back.
Thank you.
And welcome to the chairwoman's daughters. Are they still here? Right here. Oh, yes, yes.
She outed you.
Yes. Yeah. Future women members of the Congress.
Absolutely.
Yeah.
We do welcome you here today, and I thank the gentlelady for yielding back. And the chair now recognizes the chair of the full committee, Chair Rogers, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. And I, too, would like to welcome my two daughters, two most important advisors, Bryn Rogers and Grace Rogers, who are on spring break. It's great to have them in D.C. today. Yes, so welcome to the Energy and Commerce Committee. Yeah, it's great to have you. And also welcome to Carol Johnson, the administrator for the Health Resources and Services Administration, known as HRSA. And I too want to say thanks for the detailed district analysis that you've given each one of us, and also coming to Spokane and spending some time in my district. Today we will discuss several existing federal programs and proposed legislation related to healthcare workforce, primary care services, Oregon procurement competition, countermeasure injury compensation transparency, and diabetes research and treatment. The healthcare workforce shortage is leaving people without the primary care they need, which is why we're considering the Strengthening Community Care Act of 2023, led by Representative Joyce. This legislation will reauthorize the Community Health Center Fund and the National Health Services Corps that will help support both primary care services and the healthcare workforce. I am especially proud of the work community health centers in my district are doing to expand services and increase job opportunities. New Health currently offers a medical assistant pre-apprenticeship program in partnership with local high schools. They are also working with a local school district to develop workforce training center where rural high school students can gain access to clinical and non-clinical internships. Additionally, Chaz Health in Spokane is giving high school students the opportunity to participate in training sessions where they can learn about the different aspects of the health clinic and related professions. I'm hopeful that these efforts will help bring more healthcare workers into our community. Next, we'll discuss proposals to continue the Teaching Health Center Graduate Medical Education Program funding. I'm a longtime supporter of this program, which helps to bring more primary care doctors, OBGYNs, mental health providers, and others to rural areas. Spokane, Washington has recognized this and is a national leader on recruiting the next generation of healthcare workers. The mandatory funding for this program runs out September 30th, and I am committed to working to extend it. I hope that we can come to a bipartisan agreement and find the offsets needed. We will also consider the National Nursing Workforce Center Act of 2023, led by Representative Young Kim. This bill will help enhance existing state-based nursing workforce centers so that we can better access workforce challenges and address any gaps. I'm thankful for Representative Bouchon's leadership on the securing of the U.S.-Oregon Procurement and Transplantation Network Act. It will allow for HRSA to make the Oregon Procurement and Transplantation Network process more competitive, with the ultimate goal of making organs available to more people in need. One area where more work needs to be done. We will also consider a proposal to increase transparency within the Countermeasures Injury Compensation Program. This is administered by HRSA and provides compensation for covered injuries or deaths that occur as a direct result of using certain countermeasures used to treat ailments from a public health emergency or security threat. Lastly, we will discuss two programs critical to improve the lives of people with diabetes, including Representative Bilirakis's Special Diabetes Program Reauthorization Act of 2023 and Representative Cole's Special Diabetes Program for Indians Reauthorization Act of 2023. With that, I'm looking forward to today's discussion, and I yield back.
The gentlelady, the chair yields back. The chair now recognizes the ranking member of the full committee, the gentleman from New Jersey, Mr. Pallone, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. Today, the committee continues its critical work of strengthening our healthcare systems by building a stronger healthcare workforce and improving access to primary care. I'm delighted that we'll be considering my bill, the DOC Act, which permanently authorizes and increases funding for the Teaching Health Center Graduate Medical Education Program. And this program supports the training of primary care medical and dental residents in high-need communities. It's the only federal program that invests in this training of future physicians in a community-based setting rather than a hospital setting. And this is important for a number of reasons. We know that physicians often choose to practice close to their training sites, By moving primary care training into the community, teaching health centers help to address the workforce shortages in underserved areas and increase access to primary care. This program has been incredibly successful since it was established by the Affordable Care Act. Today, there are 72 teaching health center programs in 24 states, with 969 medical residents handling more than 1 million patient visits annually in rural and urban communities. It's because of the success that the program has been reauthorized several times with strong bipartisan support. Reauthorization is critical, but oftentimes these reauthorizations have often been short-term, leaving the program in a state of uncertainty. The threat of expiration makes it difficult for teaching health centers to plan and recruit for their residency programs. Low funding levels also jeopardize the sustainability of programs and their ability to address primary care workforce shortages in underserved areas. Unfortunately, unlike the Medicare Graduate Medical Education GME program, which funds GME slots in teaching hospitals at over $16 billion a year, the Teaching Health Centers program is not permanently authorized or funded, and my bill provides the long-needed security that these programs have asked for. It will create a reliable stream of doctors for high-need communities with funding for 48 new programs across the country and creating an estimated 1,060 new residency slots. It's still a tiny fraction of the GME slots that we fund in teaching hospitals, but this kind of investment is exactly what we need to increase access to primary care in underserved areas. We'll also discuss legislation that will extend funding for community health centers, which provides primary care to more than 30 million people across the country, including many living in poverty and in rural areas. While I'm disappointed the funding included in this legislation today does not reflect increases in the cost of providing care, it is critical that we do not allow this funding to lapse. So I'm pleased that the legislation we are discussing today provides for long-term stable funding for these centers. We'll also examine legislation that will reauthorize other expiring public health programs, including the Special Diabetes Program and the Special Diabetes Program for Indians. Both of these programs provide critical research and care. In particular, the Special Diabetes Program for Indians funds critical treatment and prevention efforts for American Indians and Alaska Natives who have the highest prevalence of diabetes in this country. I'm also pleased we'll be considering legislation introduced by Representative Blunt Rochester to address shortages and bolster the nursing workforce by expanding state-based nursing workforce centers and establishing a national nursing-focused research center. We'll also discuss legislation that seeks to improve existing programs at the Health Resources and Services Administration, HRSA, including the Oregon Procurement and Transplantation Network, or OPTN. More than 6,000 Americans die each year while waiting for organ transplants, and this problem is even more pronounced for people of color and people in rural communities. HRSA has undertaken a number of efforts to modernize the OPTN, and the legislation before us today seeks to complement those efforts. It would make OPTN contracts more competitive in order to increase oversight and enhance the performance of the program. So I look forward to continuing work with my colleagues on these important pieces of legislation, but I'd like to once again request that the committee immediately schedule a hearing to examine the very real health impacts of all Americans by these extremist right-wing judges who are attacking the federal drug approval process by the FDA. Today, we expect a decision from the Supreme Court, but the decisions to date challenging FDA's decade-old approval of the drug mifepristone are not grounded in science or in law. We should hold a hearing on the detrimental impacts these decisions could have on the drug approval process so we can ensure Americans continue to have access to FDA-approved medication. There's no time to wait, and that's why every Democrat on this committee has requested the Republican majority schedule a hearing immediately. We must examine the very real impacts that these dangerous court decisions could have on the American people. And with that, Mr. Chairman, I thank you and I yield back.
I thank the gentleman for yielding back, and I will, the chair will move into witness testimony. And our witness today is Carol Johnson, Administrator of the Health Resources and Services Administration at the Department of Health and Human Services. We appreciate you being here today and look forward to discussing these bills before us with you. But you are now recognized for 5 minutes for your opening statement.
Thank you so much, Mr. Chairman. Chair McMorris-Rogers, Ranking Member Pallone, Chair Guthrie, Vice Chair Bouchon, Ranking Member Eshoo, and members of the subcommittee. Thank you for the opportunity to speak with you today about improving primary care and the healthcare workforce. I'm Carol Johnson, Administrator of the Health Resources and Services Administration, the agency of the Department of Health and Human Services that supports delivering healthcare in the nation's highest need communities, building the healthcare workforce, improving maternal and child health, supporting individuals with HIV, and meeting the healthcare needs of rural America. I'd like to begin by thanking the subcommittee for your longstanding bipartisan support for HRSA's programs. With your help, we've made significant gains in expanding access to healthcare services, particularly in communities that have struggled for far too long to recruit and retain healthcare providers and access high-quality care. Yet we know there is much more work to do. I particularly appreciate the opportunity to focus today on three vital HRSA programs that are designed to help meet these needs. Mandatory funding for each of these programs is expiring at the end of this fiscal year. First, the Community Health Center program, which provides high-quality, cost-effective care to 30 million people through 1,400 local health care centers operating nearly 15,000 sites that see patients regardless of their ability to pay. Health centers are a vital source of care for individuals and families who are uninsured, people who live in rural areas, folks who are enrolled in Medicaid, and others who find it hard to find a doctor or pay for the cost of care. Second, the National Health Service Corps program, through which we provide scholarships and loan repayment to students and clinicians in return for them practicing in health professional shortage areas. Last year, at a time of critical workforce challenges across the country, we reached a historic high of 20,000 National Health Service Corps clinicians practicing in underserved and rural areas thanks to this program, as well as about 3,000 medical students currently receiving National Health Service Corps scholarships in return for their service commitment to practice in high-need communities. And third and finally, the Teaching Health Center Graduate Medical Education Program, which funds medical and dental residency programs in settings like health centers, recognizing that most primary care takes place in community settings, not acute care hospitals. This fiscal year, by the end of this fiscal year, we'll have close to 1,100 primary care medical and dental residents in training in these community settings, with recruitment of new residents for Resident Match Day 2024 beginning as early as this fall. The President's fiscal year 2024 budget includes 3 years of mandatory funding for each of these critical programs. Multi-year funding will help to prevent disruptions in care or training for millions of patients and thousands of students and clinicians, while also giving health centers, medical residents, and students predictability and confidence in the sustainability of these programs as they grow. With respect to health centers, the proposed budget includes funding to sustain current services and reach more people in need through longer hours and additional sites. Importantly, the budget also recognizes the overwhelming need to better integrate mental health and substance use disorder services into primary care by both funding and requiring behavioral health as a health center service. With respect to the National Health Service Corps, the budget would allow us to maintain the historic level of 20,000 providers currently practicing in health professional shortage areas. And for teaching health centers, the budget would ensure no disruption for current residents, allow teaching health centers to take on new residents as current cohorts complete their training, and help programs with planning grants, programs that currently have planning grants to begin to come online. I'd like to emphasize the key point that clinicians who are trained through these two programs tend to stay and practice in rural and underserved communities, yielding a valuable long-term return on the federal government's investment in these programs. I've recently had the opportunity to visit a host of healthcare centers, including those that serve individuals experiencing homelessness, school-based health center clinics, health centers that are partners in our HIV work, in our Cancer Moonshot work, and others that demonstrate how much health centers are reflective of and trusted by the communities they serve. I've also had the opportunity to meet with National Health Service Corps members who to a person report that the National Health Service Corps has helped enable them to practice in the community where they want to serve, often a rural community, and often without National Health Service Corps money, they would have had to make a different choice about their practice. In addition, I've had the good fortune to visit a couple of teaching health centers, both with Chair McMorris-Rogers and a planning grant awardee with Ranking Member Pallone, to see up close and in person how important this program is to the next generation of the healthcare workforce and really building primary care in the communities where we want people to serve. These are just a few examples of the exciting and important work happening in communities across the country as a result of these critical programs, and I look forward to working closely with the subcommittee to sustain and build on this work. Thank you, and I look forward to your questions.
I thank the witness for her statement, and we'll now move to member questions, and I will begin questioning and recognize myself for 5 minutes. So Administrator Johnson, HRSA operates workforce programming both in scholarship programs and loan repayment programs, as we've discussed just recently. Thanks for the meeting. In exchange for individuals working in medically underserved communities. So what I want to kind of explore is staying in medical served communities, as we talked about before. So can you explain how HRSA measures success within these programs? And for providers practicing in healthcare provider shortage areas, do you have long-term data on how many of those providers stay within the communities in which they're practicing or practice in other healthcare provider shortage areas?
Thank you so much for the question, Mr. Chairman. It's really important to us that we are tracking as well as we can continued participation, continued practice in the communities where we're encouraging people to serve. So we, as a matter of practice, we know how long people are practicing as part of their service commitment. That is part of their contract with us through the National Health Service Corps, and in some instances, we're able to offer people continuations that keep them in a community longer if they continue to have eligible medical debt. But we also are tracking whether people stay in underserved and rural communities. We do that most directly through our 2-year survey tracking, which shows our rate of people continuing to practice 2 years out from when they've completed their service agreement, not when they start practicing in the community, but when they've completed their service with us, and so they're no longer under contract with us. And that retention rate is 86%. And then what we are working to do and what we have been doing is building the capacity to continue to monitor and be informed by where people choose to practice beyond that. And we're working closely with CMS on national practitioner identifier data so that we can continue to monitor that over time.
Okay, thank you. And also, I know that we want to get people out into these areas through the programs that we just discussed and hopefully remain in the areas. The other way that we like to do it is in teaching health center graduate medical education if they're in those same kind of areas. So I guess my question is, how many residents practice within the same area or community within a healthcare provider shortage area, especially in rural communities?
Yeah.
So how does that get people out into how does the graduate medical education get people out?
I appreciate the question, sir. The Teaching Health Center graduate medical education program doesn't have the same kind of service commitment tied to it that the National Health Service Corps does. Right. In the National Health Service Corps, you get our resources in return for practicing, and so then you're obligated to do that. In the Teaching Health Center program, our model is to try to make sure that we're training people in the communities where we hope that they will continue to serve by having people have direct experience of working in rural areas, in underserved communities. And we find, after our residencies are completed, now, as Mr. Pallone mentioned, we have about 1,400 people who've completed the training. More than half of them are still in their communities, and we're continuing to work to ensure that we're doing everything we can to keep people in rural and underserved communities.
So how would you define the success of those programs? And I know that you measure, and you had 86% staying for. So I guess an anecdotal or ways, how would you define success in these?
I think that from the strict requirements of the law, our success is the overwhelming demand we have for people who come to these programs. And the reports we get from people who come to these programs that they would have made a different choice about where they had to practice if not for these programs giving them the support to pay down their medical debt, to let them to go to communities that are underserved or rural, that allow them to do that work, which is our shared goal and why these programs have been in place for so long, and we've all worked to continue to grow them. I think it's also an added benefit of these programs that we see people continue to stay in those communities long after their obligation to us, and that is part and parcel of what I suspect the clinicians on this panel would say, which is what we see, which is that people tend to stay in the environments and communities where they train or where they have mentors or where they start their practice. And so we get that benefit from the programs as well.
Well, and it's important to have these graduate medical programs outside of the bigger city, in the rural areas, because, a lot of southern states particular, like Alabama, the universities are in Tuscaloosa and Auburn. But the teaching hospital, the medical centers in Birmingham and Mississippi the same way. Oxford's where their main school is, Starkville, which are small towns. And then there are medical centers in Jackson, Tennessee, Memphis versus Knoxville's not a small town. But it's important, and I'm going to close without responding because I'm out of time, but it's important that we get outside of those major health centers and get people in the community. So they'll hopefully put down, as we talked the other day, you're graduating from medical school and residency, you're almost at the time. You're putting down roots and picking where you're going to be, and it's a good opportunity to be exposed to rural areas if they haven't before. So thanks for that. I appreciate that. I now recognize the ranking member of the subcommittee, Ms. Eshoo, for 5 minutes for questions.
Thank you, Mr. Chairman. In 1997, this subcommittee held a joint hearing with the Senate Labor Committee to review our nation's system for organ transplant. I was at that hearing, and I've long remembered it, and how the witnesses from the United Network for Organ Sharing seemed to resent any questions being asked of them. That's what stands out to me from that hearing, amongst other things, but I recall that very well. Now, 26 years later, that organization continues to have a stranglehold on the Organ Procurement and Transplantation Network, OPTN, which has been plagued by inefficiencies, oversights, and errors along the way. I know a key part of your plan to modernize the transplant system is to establish a competitive and open bidding process for the next OPTN contract. Why don't you tell us in your words why you think this is necessary?
Well, thank you so much for the question, Ranking Member. You know, if you're an individual or your family member is in need of an organ transplant, this is the absolute most critical system that you depend on to make sure that the system is fair and treats everyone the same and gives everyone equal access, and that it's run well. And my responsibility in this seat is that it's run well. And as you point out, there has been, you know, the statute is 40 years old, and there have been limited opportunities, limited work in the past to modernize that, which is why we're so excited to work with the subcommittee on modernizing the system. We think that we need best-in-class contractors rather than having all functions of the organ procurement and transplant network tied up in one single competitive bid. We think there's the opportunity for competition here, which will
Let me
allow us
ask
to
you,
have
because I only have 2 minutes and 43 seconds left. In fiscal year 24, the budget proposal, the president requested congressional authority to update tools governing the OPTN. Do you think that the legislation that we're considering today fulfills this request?
I think we are continuing to provide TA to the committee on the particulars of the legislation,
Okay.
but we are very pleased to be able to work with you on
Good.
this going forward.
Great. When the Community Health Center Fund lapsed for 5 months in 2017, how were the community centers, health centers, impacted? And what would happen, very importantly, if this Congress allowed the community health centers authorization to lapse again?
Yeah, thank you for the question. I mean, nothing is more important, particularly at this moment in healthcare delivery, than predictability and stability of funding, particularly as healthcare facilities are trying to recruit new workers, trying to hold on to their current workforce. You know, workforce is a big challenge in the field right now. And instability in funding or fear of not being able to maintain their capacity, it not only creates disruption in their day-to-day services, but it really creates challenges with stability of the healthcare workforce, and everybody's competing for their workforce.
Okay. As of April 1st, certain states have begun removing Medicaid recipients who are no longer eligible for the program, and more than 40 states will begin this process in the coming months. How are the community health centers preparing for this change?
Thank you for raising this question. This is an incredibly important moment for the people that health centers serve. And it's important that we ensure that people who remain eligible get redetermined and maintain their Medicaid eligibility. Those who aren't can get to affordable marketplace coverage. And we're using our sisters at health centers to be able to do that. We're providing a little bit of extra funding to our state primary care offices to coordinate that. But if people who otherwise would be eligible lose coverage, health centers will still need to see them, which puts an even greater burden on health centers at a time when we have we are approaching this issue with respect to continuing funding.
Terrific. Thank you for your leadership. And I'd like to point out that our former chairman of this committee, Congressman Greg Walden, is here. It's great to see you, Greg. You can come and sit behind me if you'd like. It's wonderful to see you. A friend to all of us. Really great to see you. I yield back, Mr. Chairman.
The gentleman yields back. He would like to sit behind you, but he couldn't admire his picture all. That's why he did from sitting there. A portrait, I should say. I'm not a picture. The chair now recognizes Dr. Burgess from Texas for 5 minutes for questions.
Thank you, Mr. Chairman. Good to see you again, Mr. Chairman. Always welcome in this hearing room. I do have a number of questions, Ms. Johnson, on the 340B program. I may run out of time, and I may need to submit those for the record. I do need to ask the Sickle Cell Disease Partnership had asked that their statement for the record be made part of the record. Asking unanimous consent too. So, of course, I do get to meet with doctors all across the country. They come in and they talk to me about all kinds of issues, and you can imagine after the physician's fee schedule and reimbursement, the number two issue is always workforce. So we've just been through this bad pandemic, put a lot of stress on our healthcare system, a lot of stress on our doctors. Now we've got inflation that has reared its ugly head in combination with low reimbursement. And the consequence of that is doctors are leaving practice. Last Congress, and I can't believe I'm going to say this out loud, but last Congress, Mr. Sarbanes had a very good idea about physician reentry. I don't know if he's going to reintroduce the bill this year. We were never quite able to get to a place where we could actually partner on the bill, but the concept is one that I think is worthy of some discussion, to create a training program for, in his version, it was for primary care doctors who would like to return to clinical practice, to unretire, if you will. So there's no question about it. We're at a time in this Congress we've got to be so diligent with all our spending, but would something like a physician reentry program work if federal dollars were used strictly for offsetting the costs of training and re-credentialing reentering physicians?
Well, thank you for the question, sir, and for your attention to this really important issue. I'd love to talk to you about the particulars of it, but conceptually, getting physicians who have the ability or the capacity to come back into the workforce is a great goal that I'd love to work with you on, and love to think about how we can work together to achieve that. I think that is true of nurses. It is true of the workforce writ large. And I recruit physicians to come to work in the federal government for some time, and I see them having to make choices about what credentials they retain. And I think it's really important for us to think about how to make sure we get people back into the workforce when they're able to.
Sure, after you've left the bedside, it can, for any number of years or months, it can be very difficult to then re-emerge on that path. Do you, assume that one of your principal tasks is assembling data, information available on the effectiveness of the current healthcare workforce programs?
That's right. We collect a lot of data on both the who participates and the outcomes associated with it.
So would it be possible to consolidate or reimagine some of these programs to be more effective with federal spending? Broad question, I get it, but could you do a better job?
Well, sir, we're constantly looking at the programs, both from a couple of ways. One, from the front end, to make sure everyone who can be competitive is competitive, because sometimes it's hard to apply for federal grants, so we're trying to make our entry door easier. Two, from ensuring that we're getting the best outcome data and we're not having people collect data for data's sake. And then 3, constantly looking at where can we get efficiencies in the design and implementation of our programs.
So recently, Optum disclosed they employ 70,000 physicians, 7% of the total workforce. They acquire new health systems literally every month, and they want to add 10,000 physicians a year to their growing base. Does HRSA collect data on whether the National Health Service Corps physicians, or any physicians for that matter, stay independent, or do they join these large practices?
We collect data on our National Health Service Corps members when they're fulfilling their service obligation, and then we do our 2-year outlook, and we are continually working to build to figure out where they're going in beyond that. And so, you know, we obviously are looking for where they're billing from in the future.
Sure. Well, I mean, it leads up to one of my pet peeves is in this country, because of the Affordable Care Act, it is legal for hospitals and health systems to own doctors, but doctors can't own hospitals. And we are in the best position to understand the allocation of those resources. I hope this committee will work on the concept of physician ownership of hospitals. It's one that should remain at the forefront of our minds. And Mr. Chairman, I'll yield back.
The gentleman yields back. The chair now recognizes Mr. Sarbanes from Maryland for 5 minutes for questions.
Thanks very much, Mr. Chairman, and let me thank our witness today for your good work. It's so important. And let me thank Rep. Burgess as well for saying such kind things a moment ago, apparently against all of his impulses, but I appreciate that. And I look forward to continuing to work on the physician reentry initiative, and I appreciate the conversations that we've been having over the last couple of years about, or really, I guess, over the last 6 months. I think there's good opportunity there to collaborate and think about an innovative design that can encourage that cohort to come back into the practice of medicine, particularly in those areas of shortage. And we would certainly look forward to input from you, Ms. Johnson, about how that can be designed and what sort of resources could be brought to bear to assist with this, because we understand, and you certainly understand, that the shortages across the country in just about every category of the health workforce, if not, frankly, every category of the entire workforce in the country, those shortages are significant and need to be addressed. And I thank you for all of the work that you're doing. I do also want to commend my colleague, Representative Blunt Rochester, for the work that she's been doing, and we've been collaborating on this as well in terms of advocating for funding for HRSA's efforts to collect and analyze, disseminate information about healthcare workforce dynamics through the National Center on Health Workforce Analysis, which is a very important resource for your agency and, frankly, for the country in terms of understanding what these dynamics are and making sure we're, again, being creative in addressing them. We need to enact policies that will lead to a stronger, more diverse workforce, one that can address the current and projected provider shortages that we face. In addition, there's the National Nursing Workforce Center Act, which is another bill that Representative Blunt Rochester has been working on, and I, again, thank her for those efforts. It'll be interesting to understand a little bit better what you envision the design of that could be if you get authority around it. I know that the Biden administration has made clear, including through its proposed Healthcare Workforce Innovation Program, that it definitely understands the need to comprehensively and innovatively approach healthcare workforce issues, particularly now, and there's, I think, bipartisan focus on this, as we continue to confront a mental and behavioral healthcare crisis that seems to be growing by the day, and as we are serving an aging population. So these innovative approaches have to span provider types, geographics, and other things in order to be effective, and no solution is too small to make a difference. I do know as well that there's workforce programs that provide educational, other financial assistance. You've mentioned that in terms of the core, and this idea of exchanging for service, that support in exchange for service at the community health centers and other critical access points. Can you speak just briefly? I have about a minute left, but I'd be interested to hear you speak again or emphasize what it would mean to increase our commitments to the National Health Services Corps, other service-based programs like a kind of reentry program that was mentioned earlier by Congressman Burgess. But these efforts to help us recruit, train, retain a diverse and community-focused, I think this is very important, workforce that can meet our current and projected demand.
Thank you so much for the question, Congressman. I suspect this is true for your experience as well. There's nowhere that I go to any of our grantees, to anyone in the community-based health workforce, where workforce isn't the first, second, and third list on their priorities of the issues that they're facing right now, which is why we think it's so critically important to sustain the level that we're at when it comes to what we've been able to do with the National Health Service Corps and be able to help place clinicians in the communities that need them most in return for loan repayments and scholarships, that service commitment is so critical. We also think, outside the scope of the hearing today, but we also think the other investments we're making in our budget, as you pointed to, our new innovation program that would really help bubble up good community-based ideas for how we more effectively train and more efficiently train in the healthcare workforce is a vital pillar of how we kind of move the process forward. Our new investments in training more mental health providers, our new investments in breaking some of the bottlenecks that make it harder to move more people into nurse training. We really think that comprehensively the budget is focused on workforce as a priority.
Thanks very much. I yield back, Mr. Chairman. Appreciate it.
Thank you. The gentleman yields back. The chair now recognizes Chairman Morse Rogers for 5 minutes for questions.
Thank you, Mr. Chairman. In a report published in December of 2015, GAO reported that HHS has 72 workforce programs that were funded in FY14. In that report, GAO looked at the 12 programs with the highest obligations. 7 of those were at HRSA, including the National Health Services Corps. How many workforce programs does HRSA currently administer?
I believe our workforce number now is about 50.
Okay.
And
Well,
that is
how
if
many
you consider the
workforce
individual
programs?
programs.
So 50 different workforce programs?
Different funding opportunities.
Okay. And then would you speak to how you measure performance outcomes of these programs?
Yeah, thank you for the question. Our performance outcomes is a weighted factor in awarding our grants. We make sure that we are collecting outcomes associated with the grant that will factor into future funding for the potential awardee. It factors into decisions about the current award, and then we collect performance metrics in detail about the participants in the program and the outcomes associated with the program.
Okay. Could you provide the committee with an updated list of the programs, including basic funding and performance?
Absolutely.
Okay, thank you. As I mentioned in my opening statement, I've been a longtime supporter of the Teaching Health Center GME program. I've led its reauthorization of the program during several congresses, and I understand HRSA plans to use resources from the American Rescue Plan to expand to new residency programs. How will this impact existing teaching health centers like the Spokane Teaching Health Center in my district?
Thank you so much for the question, and thank you for your leadership on this issue, Madam Chairwoman. It's been incredibly helpful to have the impact of your vision here and what it means for our residents on the ground. And so inspiring to hear the residents we talked to in Spokane about how they intend to continue to work in rural communities. The President's budget is actually built so that we can both take advantage of resources that we've had from the American Rescue Plan to help new there's a lot of interest in the health center program, the Teaching Health Center program, and so to help new folks plan and develop and get ready to potentially apply in the future. But our budget is built to fund current awardees, and then over time, be able to bring on new folks if they meet the accreditation thresholds going forward and they're competitive.
Okay. In 2019, GAO reported that between 2010 and 2017, community health centers saw an increase in revenue coming from insurance, both public and private pay. How has health centers' revenue changed since 2017?
I can't speak to the details, but I can tell you that what has happened is that health centers have continued to be the resource in communities for people who are underserved and or underinsured. And so across the country in communities, whether they've expanded Medicaid or not, health centers are still the resource that is seeing people who have who lack health insurance or who have Medicaid and don't have another usual source of care.
So does HRSA anticipate any further changes to the public and private revenue sources the health centers receive?
I think the one thing that we did see was some growth in people, a small growth, but people who got marketplace coverage, who had previously been uninsured, may continue to see their health center provider for the continuity of care.
Okay, thanks. As a mom with a son with Down syndrome, I'm extremely concerned by the continued reports of individuals with disabilities being denied an organ transplant solely based upon an individual's disability. As the agency tasked with administering the Organ Procurement and Transplantation Network, or OPTN, what steps has HRSA taken to address discrimination against individuals with disabilities in the organ transplant system?
Thank you so much for the question. We are laser focused on reforming the system so that we have better accountability and better transparency and oversight in the OPTN system. And part of that is about bringing more competition into the program so that the structures, the functions that govern our IT and our policy and our governance. Right now, our vendor, the Organ Procurement and Transplant Network, and the private corporation that runs outreach and the like is the same vendor. And we think that we need to separate the boards, have more accountability in the board, and that will be a venue for us getting better fairness and equity across the system.
Okay, well, I appreciate hearing more about those additional steps that you're taking at HRSA. Thanks for being here today.
Absolutely.
I yield back.
Thank the chair, yields back. The chair now recognizes the ranking member of the full committee for 5 minutes for questions.
Thank you, Chairman Guthrie. I appreciate the opportunity to discuss these important programs today, and thank you and Administrator Johnson for being here today, and also thank the administrator for coming to my community health center in Red Bank recently. I really appreciate you doing that. However, before I discuss primary care, I must note that I remain very concerned by the recent efforts of extremist federal judges putting their beliefs between doctors and their patients, particularly with regard to the abortion bill, mifepristone. If we're to have a full discussion on ways to grow our healthcare workforce and protect patients, we must start with ensuring that healthcare providers can provide the care their patients need and prescribe the medications that have been proven safe and effective. And I hope my majority colleagues recognize how detrimental these recent court actions, like the FDA versus Alliance for Hippocratic Medicine, could be, not only for patients, but also for providers. So let me ask Administrator Johnson about this. From your perspective, what impact do you think these decisions like this recent one in FDA versus Alliance for Hippocratic Medicine by what I consider extremist judges have on the healthcare workforce in this country?
Well, thank you for the question, Ranking Member. Obviously, there's obviously ongoing litigation, so I won't speak to the particulars of that. But I will say, you know, in healthcare services for a very long time, we have recognized the value and the importance of the relationship between the provider and the patient, and respecting decisions that happen between the provider and the patient. And that's what our policies and our training programs are organized around. And that's what's important, is making sure that we're centered on the patient and the provider.
Well, let me ask, I guess Chair Rogers isn't here. Let me ask Chair Guthrie. Every Democratic member of the committee sent you and Chair Rogers a letter last week requesting that you immediately hold a hearing on the impact of this case. And I think we have to hear from experts on how detrimental this case could be for women and for all the Americans who rely on FDA-approved drugs. Even the pharmaceutical industry agrees that this case has dangerous precedent-setting implications. I haven't received a response, so if you could tell me, Chair Guthrie, whether you will hold a hearing on this important issue.
Well, we're going to continue to do oversight over the FDA, so we'll have that under our committee's jurisdiction.
Well-
Continue to do oversight.
Do you know when that's likely to be?
I don't have a.
I mean, the problem is, that today, I don't know if anything happened this morning yet, but as of about, I think, midnight tonight, the stay of the lower court's decision could be lifted unless the Supreme Court acts, and that would mean that this pill would not be available for the most part in the country. And so I really think we need to do something immediately, and I just want to reiterate that again. We should have the hearing as soon as possible. But I do want to see if, I know I only have a little time left, I want to ask Administrator Johnson about the primary care workforce. And many people in this country struggle to access primary care because of a lack of providers. We've already discussed this. There was a report from the Kaiser Family Foundation that said over 97 million Americans live in a designated primary care health professional shortage area. And of course, the Teaching Health Center Graduate Medical Education Program is designed to address that. So let me ask you a question. Can you explain the value of medical residents training in community-based settings rather than in hospitals, and what kind of impact the program like the Teaching Health Center Graduate Medical Program has, particularly in underserved communities? You've got about a minute.
Well, I will just say that we are so excited about the way this innovative program has sort of changed the game for what primary care training can and should look like, and anchoring it in the community, in the places where we want primary care providers to serve, makes it more likely that they'll practice there, gives them the kind of experience and access to the kind of training experiences that will then be useful to them in their primary care practice. And so it has been transformational, and it makes a huge difference in communities across the country.
And just the challenges, particularly because of unstable funding. We've had this discussion about how if you do this short term and the funding's not there, it really presents challenges for the program, if you could respond.
It's been very difficult for programs to plan appropriately. Funding cliffs make it hard to know whether with security you can recruit your next class of residents. It makes it hard for residents who really want to train in the community to make that commitment if they're not sure the funding is there. So it creates challenges for programs, existing residents, and future residents.
Thank you so much. I appreciate everything you've been doing on this. And thank you, Chairman.
Thank you. The ranking member yields back. The chair now recognizes Mr. Griffith for 5 minutes for questions.
So I have lots of questions about the Black Lung Program, but unfortunately, all the questions I have are in areas that are not under your jurisdiction, so I'll have to save those for somebody else.
Okay.
But there are a lot of things I think we can do to help Black lung victims as we move forward. So if I can ever be of help to you on that, let me know.
I very much appreciate that, and we will do all we can with from our vantage point as well.
Thank you. So let's talk 340B. Some of the nonprofit hospital systems, in my opinion, have been exploiting 340B program to reap huge profits that fuel expansion into affluent communities instead of continued reinvestment in communities of greatest need. In fact, my district is relatively economically stressed. We're 409th out of 435 for median household pay. So I've got for-profit hospitals that are doing a substantial amount, and my hospitals in my area that get 340B are using it, through my analysis at least, they're using it to help people. They don't have much choice, frankly. So it's a great program, and I support it. That being said, there are bad actors out there, and one notable example happened in Virginia, in what was then the district of my friend Don McEachin. And it appears that Bon Secours hospital system used the Richmond Community Hospital, which is clearly 340B eligible, to expand its use of 340B at the expense of Richmond Community Hospital and their patients in that economically stressed community. Over the years, services at the Richmond Community Hospital were cut and departments closed, while at the same time, Bon Secours, it appears, was transferring millions out of the Richmond Hospital to other hospitals within the system. Some in their system maybe even as far away as Ohio, I'm told. So, this is important to me. How do we make reforms? What exactly do you plan to do with the information that you all are collecting? I know you've sent a number of letters out to hospitals asking them how they're using it. What do you plan to do with that information when you get it? And if you don't get it, should we be passing legislation? I know I'm adding 2 or 3 things in there. Should we be passing legislation for more transparency? Because I made a promise to Don that I wouldn't let this go, and neither one of us knew he was going to pass away. He called me a couple of weeks before his death and said, hey, as chairman of Oversight and Investigations on Energy and Commerce, I need your help. I promised him I would help. Help me keep my promise.
Well, thank you so much for raising this issue. Thank you for your work on this issue. I had the opportunity to talk to him before he passed as well on this topic, and know how passionate he was about making sure resources are going to the places where they're intended. As you noted, 340B plays a vital role for some critical safety net providers, but we need to make sure that there's accountability and transparency in the system. Our recent letters to a number of covered entities were part of that process. Our request in the president's budget that we actually get specific designated authority for reporting, for covered entities to report on the savings from the program and how that's benefiting the communities they serve is a specific ask we have made in the budget. We look forward to working with you on that. We really would benefit from your assistance in making sure that we have all the tools necessary. As you probably know, we're in a lot of litigation on 340B, and so clarity about our scope and authority would be incredibly important to us.
All right, and I look forward to working with you on that. Let's switch gears and go to community health centers. Another group that does great work in my region. Glad to have them, but it has come to my attention in talking with some of my community health centers that pharmacy benefit managers are taking predatory actions against the health centers by effectively forcing them to sign what they believe to be unfair contracts. They're forced to sign these contracts, which include provisions which give the savings or a part of the savings back to the PBM, the pharmacy benefit manager, instead of helping the poor folks who really need these services of the health centers. So do you all have legal authority to address the matter? Or is this an issue that we need to, Mr. Carter and I need to put legislation in on?
I would
Oh, I
ask
shouldn't have left out Ms. Harshbarger.
Thank you. I would ask for your assistance here. As you may know, we also have had the issue of manufacturers not selling to covered entities via their contract pharmacy arrangements. We issued violation letters associated with that. That has been a source of considerable litigation as well. Clarity about our authority and scope here to be able to, because I share your view that accountability in this system is critical and would love to work with you on that.
All right, I look forward to working with you, and if we need legislation, you've got 3 people on this committee that are more than happy to help you in any way you need.
Thank you.
I yield back, Mr. Chairman.
Thank you. The chair yields back, and the chair now recognizes Mr. Cardenas from California for 5 minutes for questions.
Thank you very much, Chairman Guthrie, and also Ranking Member Eshoo for holding this very important hearing. And thank you, Administrator Johnson, for coming forward. I like your answers. Your answers are very concise. You're not copying what they do in the Senate, which is filibustering. Sometimes some of our witnesses kind of do that, but thank you for being so direct with your answers and so helpful. I'm concerned about shortages in pediatric care. We need to look no further than this past winter when a combination of COVID, RSV, and flu wreaked havoc on our kids and left many without access to care. Administrator Johnson, what role will increased funding for the THC GME program play in boosting the pediatric care workforce? And how can the program increasingly prioritize physicians who will work in medically underserved communities?
Thank you so much for the question, Congressman. The Teaching Health Center Graduate Medical Education Program, because it is so primary care focused, we have worked really hard to encourage programs to stand up pediatric programs. We have a few. We hope with our planning and development grants we will get more. We've trained probably close to 50 pediatricians through the program so far. We hope to continue to grow that as we go forward to ensure that this vital program is actually doing what we want in terms of training not only internal medicine and family medicine docs, but pediatricians in community-based settings.
Thank you. And also, I want to take a moment to discuss the critical role that community health centers play. Personally, I grew up in a household of 11 children and 2 parents, and for a good portion of my childhood, we did not have health coverage. We didn't have access to health care. Honestly, it came down to prayers and aspirin, which was the way that we handled things most of the time. And the place where we showed up, unfortunately, was the emergency room. And that still goes on to this day with too many families, whether it's one child or many children. And that we need to do what we can in this great country to make sure that that is not the alternative. It's either no coverage or going to the emergency room. CHC and FQHCs literally are a lifeline for families like mine. For example, FQHCs, when I was about 10 years old, were created, and one of them showed up in my community, and that's when we finally got access to healthcare. They're the reason why I received care when I was 10 years old and beyond. NAVHC was the place that we went, and other CHCs are still doing this essential work in my district to this day, and they're getting creative about caring for as many people as possible. For example, some are using mobile clinics to provide care to hard-to-reach populations. Also, in many cases, centers are even keeping extended hours to try to keep ERs out of the picture as much as possible. I'm proud of the work that the CHCs do in my community, and so many questions are really focused on how to grow these life-saving resources. So, Administrator Johnson, what else can we do from a policy standpoint to increase the reach of CHCs, especially in medically underserved and rural communities?
Oh, thank you so much for the question, because that is what our budget is about. Our budget is saying we not only need to sustain where we are, but this is a proven model and we know it works, so we need to ensure that we are building on it to get to more people in need. And so our budget focuses on new access points. We know from all the health centers that, as you said, when a health center shows up in your community, it makes a difference for families. So getting more health centers into more communities, extended hours, making sure, if you work shift work, getting to a regular office hour appointment is hard. Health centers try really hard now, but we want to invest in making sure that they have extended hours, and integrating mental health and substance use disorder services into the core of what health centers do, so that primary care isn't medical services on one side and then refer you to mental health and substance use disorder, but primary care is integrated care.
One of the big issues is workforce recruitment, and how will funding help ensure that CHCs are adequately staffed?
Yeah, the funding, the continuation and expansion of our health center resources are absolutely vital to them retaining their health workforce and growing their health workforce. And uncertainty about the future of their funding will make it challenging when it comes to retaining workforce at a time like this, when the workforce competition is so intense in the healthcare field.
Well, thank you. My time's about expired. Thank you, Mr. Chairman. I yield back.
Thank you. The gentleman yields back. The chair now calls on recognizes Mr. Bilirakis for 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate it. Again, thanks. This is a very important conversation today, as you know, and we're looking at multiple reauthorizations that provide such vital care and services for many of my constituents, for Floridians and all Americans. My question is, and I appreciate you being here, thank you. To start, I'm very thankful that legislation I'm working on to extend the funding for the special diabetes program and the special diabetes program for Indians has been noticed at this hearing. Appreciate it, Mr. Chairman. Working with my friends, Mr. Gatt, Mr. Cole, and Dr. Ruiz, we have introduced bills that would provide level funding for these programs for 5 more years. These programs are vitally important, as you know, an essential resource in our nation's investment in diabetes research, treatment, education, and prevention programs. Diabetes is our country's most expensive chronic disease in both human and economic terms, affecting people of all ages, races, and in every region of our country. It is the leading cause of heart disease and stroke. Additionally, it is the #1 cause of kidney disease, blindness in working age adults, and lower limb amputations, unfortunately. Reauthorizing these programs will provide stability and hope for the millions of Americans impacted by diabetes. This is truly a bipartisan effort, and I look forward to working with all my colleagues to get these programs extended long-term. Ms. Johnson, thank you again for being here. You have not mentioned diabetes in your testimony today, but I'm sure you recognize its impact on the American people. I know that. What role do you believe the primary care workforce plays in addressing prediabetes and diabetes in the U.S. in general, please?
Thank you so much, Congressman, for your comments. And I do defer to my colleagues and the other agencies who run the special diabetes program, but know from the long history of those programs how valuable they are to the public health and healthcare services. Diabetes is it's such a it in and of itself is such a challenging chronic disease for people to manage, and the risk factors for it are just as challenging. And having an established relationship with a community health provider who often speaks your language or is from your community makes such a difference in identifying risk early, in doing the kind of modifications and work necessary to try to forestall the onset of diabetes, to try to help people manage their condition if they have diabetes. It just makes such a difference to have a usual source of care. And when you are uninsured or underinsured, having a usual source of care is very hard unless you can turn to a community health center that will see you regardless of your ability to pay. And those community health centers are often staffed by National Health Service Corps members. So all of this works together to make sure that we have that critical work. I would also say we run a lot of maternal and child health programs as we work on maternal mortality crises and infant mortality issues. Addressing diabetes is such an important part of that equation as well.
Thank you very much. Next question, because I still have some time. Another very important program we must reauthorize, of course, is the Community Health Center Fund. I've been an outspoken advocate for the role that community health centers play in providing whole health care for so many Americans, and I'm proud to have led efforts to reauthorize the community health center programs in the past years. I'm very grateful to join forces with Dr. Joyce, and I thank him for his leadership on this particular bill. Locally, I'm also very proud of the work that Florida community health centers are doing throughout my home state. One CHC, Suncoast Community Health Center, has developed and built its own subsidiary training academy, Suncoast Academy, that provides training for dental assistants, pharmacy technicians, and later this year, medical assistants. It's really fantastic. Several CHCs around the state have begun planning or have already implemented registered apprenticeships within their organizations. So, question for you, Ms. Johnson, again. I know that Florida CHCs are extremely resourceful, and I'm sure they are around the country as well. It's a great program, and have found creative ways to increase access for patients. You've touched on this. They have a true sense of understanding of the needs of our neighborhoods and communities. How do you intend to partner with state CHCs to support and leverage the strengths as well as their efforts to grow the workforce and expand services? If you could elaborate on that. I know you touched on it. I'd appreciate it.
Yeah, thank you. Thank you so much for the question. I mean, one of the things that I'm really excited about in the president's budget this year is a new initiative that we have proposed on the discretionary side called our Healthcare Workforce Innovation Program, which would be our way to sort of, in many ways, our healthcare workforce programs are defined by statute and we lay out what the requirements are. Here, we're really trying to get the best ideas from the field, like the models that Florida's health centers are implementing, and figure out what works and what we can start taking to scale so that we can actually be seeding some of these initiatives as well. Because we hear time and time again, med techs, farm techs, like a lot of the support, the critical folks who are early in the career ladder.
Yeah, thanks. We're going to have to round up this series of questions. And
I yield back.
it's expired, and thank you for that, your answer. I know we're going to get to more of that as you continue to talk. So, but the chair now recognizes Dr. Reese from California for 5 minutes for questions.
Thank you, and thank you for holding this important hearing today. I've been a longtime advocate for the Teaching Health Center program and have introduced bills to extend the authorization time as well as increasing funding because I believe in its mission and I believe that it works. I grew up, practiced medicine, and now represent an area that is in desperate need of healthcare providers. The doctor shortage is a nationwide problem, both in absolute terms and also in the distribution of physicians, but more acute in some communities like those in my district. where in research that I did back in 2010, there was one full-time equivalent physician per 9,000 people. And as you know, the medically underserved criteria is 1 to 3,000. So as you know, where a doctor is from and where they train are the two biggest indicators of where they will practice. So training physicians in health centers that are located in and directly serve communities in need is critical in addressing the provider shortage. More importantly, taking individuals from those underserved communities and training them in their underserved communities increases the probability that those communities will have physicians who will care about them and take care of them. That's why I'm proud to have joined Ranking Member Pallone to introduce the Doctors of Community Act, which will permanently fund the Teaching Health Centers program and result in the largest expansion of the program since its creation. Administrator Johnson, is there demand for this program on the physician side, meaning do teaching health centers receive a significant number of applications for residency slots, or are they struggling to get residents to apply?
Oh, there is demand for this program, Congressman. There is a lot of interest, both in establishing residency programs and then in recruiting residents themselves to the programs. There's a lot of interest and a lot of enthusiasm. I think people who have a dedication to community-based service, who want to practice in high-need communities or rural areas, are drawn to this program. What is challenging, both for programs and for the recruitment of residents, is if there's instability in the program and the program funding, or folks not having confidence that it will be there for them through the full term of their residency.
And what do you see in terms of outcomes for this program? What's the percentage of physicians that stay in the communities that they train in?
Well over half of them stay in the communities or in underserved communities, but we continue to see that number increasing, and we know that people are interested in making sure that we know that the data all supports that people who train in the community are more likely to stay in the community.
So jumping topics to address another one of my policy priorities, in this hearing we're considering HR 2547, the Special Diabetes Program for Indians Reauthorization Act of 2023, which I introduced with Congressman Cole. Although these programs do not fall squarely within HRSA's jurisdiction, the resources provided by the SDPI program have significant impacts in the communities that HRSA serves and the health workforce that provides diabetes care. And as a doctor, time and time again, I saw patients in the emergency department with preventable conditions related to their diabetes, the silent killer. And this problem is continuing to get worse, particularly in communities of color, with low access to health care, prevention, and chronic care for their chronic illness. And data shows that the incidence of type 1 diabetes is increasing among all population. Nevertheless, American Indian and Alaskan Native populations have the highest prevalence of diabetes, which lead to renal failure, neuropathies, amputations, blindness, and other chronic comorbidities. I believe that reauthorizing this program is critical to reducing the incidence and mortality of diabetes, which overall is the 7th leading cause of death and the #1 cause of kidney failure and lower limb amputations and adult blindness. What actions is HRSA taking to address the growing incidence of diabetes, and how is HRSA coordinating with other agencies such as the Indian Health Service to serve communities acutely affected by diabetes?
Yeah, there is no doubt how critical the special diabetes programs are to both the work that they do directly, but then also building the models that our primary care providers can learn from and implement. And that's what we do, is create learning environments and learning collaboratives across health centers so that we're sharing the best practices and knowledge so that we're able to help do the cutting edge prevention and treatment work.
Thank you. I do believe that these teaching health centers should also participate in pipeline development programs, working with local high schools in these underserved communities, local colleges, and medical schools, so that from an early start, they can start in high school, finish in medical school and residency training, like the Future Physician Leaders Program that I initiated back when I was Senior Associate Dean at UC Riverside School of Medicine.
Terrific. We also fund on the discretionary side some of those programs, so building those bridges is really important to us.
Wonderful. Thank you.
Thank you. The gentleman yields back. The chair now recognizes Mr. Johnson for 5 minutes for questions.
Well, thank you, Chairman Guthrie, and thank you, Administrator Johnson, for making yourself available today. I also want to thank you for you and HRSA for your response to the February 3rd train derailment in East Palestine, small village in my district. It's critically important that all levels of government continue to work hard and hand in hand to ensure the health and long-term viability of that small village that I represent. Locally, the Community Action Agency of Columbiana County stepped up immediately after the East Palestine train derailment, deploying a mobile health unit to a local church that enabled physicians and toxicology experts to perform health assessments for those individuals looking for care in the aftermath of the disaster. For residents without a physician, the health center provided quality medical and dental care to help the community recover from the event. So my question for you, Administrator Johnson, yours is the primary federal agency responsible for improving access to health care for people who are uninsured, isolated, or medically vulnerable. And I would argue that that encapsulates the village of East Palestine. What has HRSA's involvement been with ensuring access to those medically vulnerable citizens there?
Yeah, thank you so much for the question and for recognizing the resources we were able to provide soon after the incident to ensure that the health center in the community was able to staff and support the mobile clinic and other resources. We think it's vitally important that health centers are able to surge in a response because they have community relationships and because they know where their patients are. Often, for some of our centers that serve individuals who are experiencing homelessness, they are the connection to that individual and their services. So we're anxious to continue to build on that work, and we're delighted to be able to do that short term, and we look forward to working with you and with the community on response going forward.
Okay. And what are you doing to coordinate the efforts on the ground? How have you assisted community health centers like the Community Action Agency on the ground to ensure that resources are being allocated and used efficiently and effectively?
Yeah, we have a partnership with state primary care offices, which are often the coordinating entity for community health centers across the state. And in the event of emergency, we often work directly with the state primary care agency to make sure that we're touching all of the relevant health centers in the community. And then we work closely with our disaster response colleagues at the at our department and across FEMA.
All right. Another broader challenge that many in my district and much of rural America deal with is workforce.
Yeah.
Every industry, from manufacturing to healthcare, is having trouble recruiting and maintaining a necessary and sufficient workforce. Why is this? I mean, it could be because Washington paid countless individuals to stay at home and sit on the couch, or because we don't have things like work requirements on able-bodied Americans to receive federal assistance. We, Washington, has incentivized people not to go to work. To this point, can you please explain for us today how the Federal Office of Rural Health Policy is working with community health centers in rural communities to train and place healthcare professionals in regions like Appalachia, where I call home?
Yes, sir. I would say, what we are seeing in healthcare is really, we asked a lot of the healthcare workforce over the last several years, and it was incredibly traumatic and stressful for a lot of people. And we have seen some people, either retire or move on to other work because of the strain of that, which is why we have made an investment in supporting the mental health and well-being of the healthcare workforce. We have done awards to medical centers across the country to help them focus on retaining their workforce by supporting their mental health and well-being. Our Federal Office of Rural Health Policy focuses on building rural residency programs so that we can train in rural communities. It focuses on making sure we're supporting the viability and financial viability of rural hospitals by providing support for them directly to ensure their long-term sustainability. We provide a ton of technical assistance in rural communities. We're very focused on workforce in rural communities.
Okay, well, my fear, and something that I would continue to sensitize you to, is that we're seeing it daily, is that these rural communities are often left behind in favor of more urban areas with regards to this program. And I appreciate it that you're sensitive to that. We've got a long way to go to equate healthcare access and the quality of healthcare for people in rural America.
No doubt
I
that
yield back.
no doubt that there's a lot of work to be done in rural America, but a lot of our National Service Corps members are in rural communities. Thank you, sir.
Thank you. I yield back.
The gentleman yields back. The chair now recognizes Ms. Custer from New Hampshire for 5 minutes for questions.
Thank you very much, Mr. Chairman. I appreciate it. Excuse me. Whoops. Thank you to Administrator Johnson for being with us today. As has been highlighted throughout this important hearing, we're at a key point for supporting community health centers. In New Hampshire, community health centers serve as a critical site of care, filling gaps in rural areas and ensuring people of all backgrounds can access the health care that they need. Cost-effective preventative care is under attack by conservative courts across the country trying to politicize our healthcare system, and it's essential we defend the healthcare providers who are delivering life-saving services. The National Association of Community Health Centers finds that overall, community health centers save the healthcare system $24 billion annually by increasing access to comprehensive, high-quality preventative and primary care. If Congress does not invest in our community health centers, American health will suffer and the cost of care will increase. I applaud my colleagues for introducing a bill that would not lead to cuts in funding, but we must do more. We know that flat funding will prevent community health centers from meeting our constituents' needs. And while I'm hopeful our colleagues in the Senate will be able to raise the funding levels, the conversation must start here. Minister Johnson, can you speak to the importance of increasing funding for community health centers and how increases could benefit CHCs in states like New Hampshire?
Thank you so much for the question. That is very consistent with the way our budget is structured. We recognize that it is vitally important that we sustain where we are with health centers, but we are not meeting the needs of communities to their fullest. And we have the opportunity to do that here, in particular in a couple of key areas. We think it's important to make sure that we're expanding health centers into communities that need more sites. Convenience and access to healthcare is critical to delivery, as is making sure that we have expanded hours in health centers. Again, people who work shift work or have childcare issues or have a host of things that can make it hard to see a doctor during normal business hours. If we can expand business hours in health centers, we can make it more convenient for people to get the care they need, and then they can go to a health center instead of going to an emergency room, which clearly costs more. And at the same time, we think it's vitally important to recognize the moment that we're in when it comes to the needs of families around mental health and substance use disorder. And time and time again, when I talk to primary care providers, they say visits that started out being about hypertension or other issues quickly become about a mental health issue. And so making sure that we can provide those services and provide that support in health centers is part of what we think is essential to meeting this moment for families' needs.
Great. You practically took the words out of my mouth because I visited a site in my district just recently, and they're embedding the mental health care in the healthcare facility and vice versa, embedding mental health care embedding healthcare into the mental health facility. So community health centers do play an essential role in combating addiction and mental health. And I'm the co-chair of the Bipartisan Mental Health and Substance Use Disorder Task Force, and I've seen firsthand the innovative ways that our health centers are helping meet people where they are to deliver the care that they need, as you mentioned, conveniently and in hours that fit people's real lives. Addiction and mental health challenges affect people of all ages, incomes, and backgrounds, which is why it's essential that community health centers remain accessible. Can you explain the importance of including mental and behavioral health funding for community health centers in future funding packages?
Thank you so much for the question. This is just vital to what primary care needs to be going forward. An individual doesn't experience a mental health condition separate from their physical health condition. They are one person, and we need to be able to treat them and when someone raises their hand and says they need help, we need to be able to meet that moment and help them. Today, health centers are only able to meet about 25% of the mental health needs of their patients and about 6% of the substance use disorder needs of their patients. We clearly need to do more to make sure that we are taking care of families and meeting their critical healthcare needs.
Great. Well, thank you so much. I appreciate all your efforts, and thank you to the committee for raising this important conversation about how we can improve access to both healthcare and mental health and substance use disorder and improve workforce. Thank you, and I yield back.
Gentlelady yields back. I now recognize Mr. Latta from Ohio for his 5 minutes.
Well, thank you, Mr. Chair, and Minister, thanks for being with us today. Health professional shortages are everywhere. And I know that when I'm out in my district, I don't think I go into a facility that it's not one of these things that's like a few people or sort of many people. I mean, it's unbelievable the numbers of individuals that we have to have filling our healthcare slots out there. And, it's everything from primary to dental to mental health, and as you were just talking about on the mental health side. But what trends have you seen in the distribution of healthcare professionals between HPSAs, and how is this distribution tracked at this time?
Thank you so much for the question, because you're right. It is not just about producing more healthcare providers. It's about the distribution of healthcare providers. Because if we just train more, those folks will go where reimbursement's highest, or where they can make enough revenue to pay down their medical debts. That's why the National Health Service Corps is so focused on not just training new providers, but incentivizing them to practice in the communities that need them most. And we do that through our health profession shortage area designations, where we work closely with states on identifying the provider to population ratios in a community, the need in a community, the distance to providers in a community, and are able to define where highest needs are and be able to place National Health Service Corps members based on need. And thanks to the resources that we've had over the past couple of years, we've been able to fund a sizable amount of the request for that. Without the resources in the president's budget to sustain those National Health Service Corps numbers, we won't be able to place nearly as many.
Wait, let me follow up on that, because again, I was just out, this is a work period that we just came back from, so I was on the road extensively. And I know that going through some of my rural providers out there, they are really struggling. And the problem then, of course, is they say, well, what we try to do is get somebody from a metropolitan area to come up for 2 to 3 days. And so they have this going back and forth. But when you're tracking this, I think it's really going to be important, because, again, I don't want to have a situation where maybe somebody, they might say that, oh, they've got somebody up here at this period of time, but they need somebody there all the time. And so, but, they're doing everything they possibly can to make sure that they can treat their patients in a timely manner. Let me go on. I understand that on the payment and reimbursement are an issue, and that there are a lot of ideas on how to expand the workforce and provide timely care. However, do you believe there are any regulatory barriers that hinder that workforce growth at this time?
Well, I think that one of the things that we're looking at with our new proposed healthcare innovation program is for the healthcare community to come to us with good new ideas for how to address workforce challenges. And sometimes what we see in some of those places is folks have suggested to us there are models that have sort of accelerated training, or they have broken through some of the accreditation issues or licensing issues or those kinds of things. And so what we're hoping is that this new program allows us to look at creative ideas from the community to break through any barriers.
Yeah, and again, following up again on this, because again, this is one of my concerns, and I'm sure it's everybody's concern. This is that scenario that everybody has in the back of their mind. What happens when we don't have sufficient number of personnel to be in a facility that is, that under regulations say you have to have X number of people, and all of a sudden they say we don't have those people, but they have a great need to serve all of these patients, that all of a sudden they can't do anymore. So, here's the horrible thought. What do they start saying? Number one, we don't accept anybody else in. Number two, we have to almost do a triage in there and saying that, well, for those who we think that don't have this greatest need, we're just going to have to release back to their families. And then what are we going to do?
Well, so I would say, sir, obviously, we have much more work to do to incentivize people to come into the healthcare pipeline, but we are looking at those kind of pipelines. Like, where do we have people who are on the first ladder in their career that we can get from an LPN to an RPN, and so that we can get more nurses in the workforce? Where do we have opportunities to bring high school students, as others have mentioned, into the workforce? So how do we do apprenticeship programs? We've been investing in community health worker apprenticeship programs to start to get people on a path to the healthcare workforce. And so while this conversation is focused on the National Health Service Corps, we have a host of investments on the discretionary side related to training more nurses, physicians, behavioral health providers as part of that effort.
Well, it's really important because, again, seeing what I saw in the last week, we're doing a tremendous job from even in our high schools. I saw things that if I told the students that I think people have been working on their PhDs and we'd have been back when I was in high school, what these kids are doing today, absolutely unbelievable. But we just have to get these people out there. Mr. Chairman, my time's expired and I yield back.
Gentleman yields back. I now recognize Ms. Kelly from Illinois for 5 minutes.
Thank you, Chair Guthrie and Ranking Member Eshoo, for holding today's hearing. Ms. Johnson, thank you for being here today. In 1 year postpartum, suicide and substance use are the leading causes of maternal death, with suicide accounting for 9% of the maternal mortality rate. Maternal mental health conditions such as anxiety, perinatal postpartum depression, and birth-related PTSD are the most common complications of pregnancy and childbirth, affecting 1 in 5 women. Among those affected, 75% go untreated. While women of color are more likely to experience these conditions, they are also less likely to seek help. What remains so surprising is 100% of these conditions respond to early intervention and/or treatment. So what current resources does HRSA have to help close the access gap to maternal mental health services, and what additional resources are needed to improve access to mental health services for moms?
Yeah, thank you so much for the question. It's such a critical issue. We talk about the maternal mortality crisis. I don't know that we talk enough about the maternal mental health needs of individuals and families. What we have been able to do at HRSA, 2 programs, we do a number of things, but 2 programs that I'm particularly excited about in this space that I think are going to make a real difference are, 1, our maternal depression and screening program. This is a program where what we're trying to do is help, in the same way we're talking in this conversation about primary care providers integrating mental health, helping OBGYNs get access to mental health experts. And so that if in real time, through teleconsultation, so that if you have a pregnant woman in your office and you are aware of significant concerns, you can get real-time teleconsultation access to mental health providers to help you manage that. So that person isn't sent off on their own with a referral, good luck getting an appointment, that it can actually happen in the office. We haven't had a ton of discretionary funding for this program, so we've only been able to fund 7 states so far, but this year we got some additional money. We think we'll get up to 14 states. We're very excited about the opportunity this program presents. And then second, I would note we have launched, last Mother's Day, we launched the National Maternal Mental Health Hotline. We've had thousands of calls to the hotline. It is 844-8339, Help for Moms. It is our way of helping moms have a safe space, and pregnant women and family members have a safe space to have a conversation, confidential conversation with a counselor. And we've seen incredible demand for it. We had a limited amount of resources to launch it. We've got some more in the last appropriations bill, which is going to allow us to do more outreach to make awareness better, and continue to bring people in and provide that kind of support.
That is fantastic to hear, and anything I can do to help you along with that, I would love to do that. Shifting gears, 17 individuals die each day waiting for organ transplant. Black people are 4 times more likely to develop kidney failure than white people, but are much less likely to receive a life-saving kidney transplant. Additionally, Black people also experience the highest rate of health failure, but receive heart transplants at a lower rate than their white counterparts. These are tragic inequities that are unacceptable. And that's why I was glad to see HRSA's leadership last month in announcing the Organ Procurement Transplant Network Modernization Initiative, long title, as our country continues to move forward at a rapid pace with new technologies becoming available every day. We owe it to our constituents to bring our medical practice into the 21st century and save lives. Yet a report from the U.S. Digital Service, the government's own top technologist, said that the current OPTN contractor lacks sufficient technical capabilities to modernize the system. And this is one of the many reasons I'm proud to co-sponsor with my colleague, Congressman Bouchon, the Secure the U.S. OPTN Act. How would opening up the management of the OPTN network to multiple contracts improve outcomes for patients?
Thank you for the question, Congresswoman. You know, I've been in this seat for about 15 months. When I first started in this role, it was crystal clear to me that we had a lot of work to do here, that the statute was old, that the systems were needed to be modernized, and our team has been working nonstop since then to really focus on what it's going to take to modernize this system. And what it's going to take is more competition, and what it's going to take is us being laser focused on ensuring we're getting best in class in all of the categories of work associated with the OPTN. And that's our priority, and that's what we're going to do. And we appreciate your help in that regard. The legislative action and additional tools will make it that much easier for us.
Well, hopefully we can get this bipartisan bill passed. And I yield back.
Gentlelady yields back. I now recognize myself for 5 minutes for my line of questioning. I want to start out by saying one of the ways we can get more physicians in underserved areas is properly reimburse primary care doctors for their services, instead of continuing to cut reimbursement in a failed attempt to control healthcare costs, which the physicians are only about 10-15% of the healthcare dollar. And in the long run, this would actually save us money because it would make our population much more healthy. I want to highlight again, Congresswoman Kelly just mentioned H.R. 2544. I'm proud to introduce that with Congresswoman Kelly. Again, it seeks to improve the system, the OPTN program, through competitiveness, because according to increasing numbers of reports, the OPTN struggles to obtain and distribute organs in an efficient, timely, and appropriate manner. In fact, it is believed that thousands of donated organs go to waste each year because the process of obtaining organs, matching them to a recipient, and transporting them is not happening effectively. With the technology and expertise available today, that is just unacceptable, and there definitely are also disparities in distribution amongst different populations of our fellow citizens. This bill allows HRSA to improve the OPTN program, clarifies that HRSA does not have to implement a single contract for all aspects of the program, and encourages a competitive process to choose the best contractors for each OPTN function. I don't have a question. Those have already been answered by you, but that's why I feel like legislative action is necessary. I also want to say I was a surgeon before I was in Congress, and during my residency in the early 90s, I spent time on the transplant service at the Medical College of Wisconsin in Milwaukee, Wisconsin. Strong, solid organ transplant program at that time and still is today. And so talking to the faculty members when I was a resident, I began to understand how the system worked or didn't work, even 30 years ago after what had been put in place 40 years ago. So I have direct experience with this, and it needs fixed. Again, I'd like to again draw your attention to the 340B program. Multiple members have talked about it. I think Dr. Morgan Griffith really outlined one of the problems that happened in Virginia. This is widespread in my view. I've been working on this for 5 or 6 years. As you know, Congress failed to establish clear parameters for the program, in my view, forcing HRSA to try to determine how it should be run. I'm in the process of working with many others, including the committee, to draft legislation to increase the transparency in 340B so that Congress and the public can better understand when the program does or does not benefit patients. And that's the goal of the program. It was instituted to make pharmaceuticals available in underserved populations, including rural America and many areas of urban America, and that is the goal. I appreciate that Secretary Becerra, who was here testifying recently, concurred during a hearing last month that more transparency is needed. Understanding that we must move forward in the most efficient, least burdensome manner possible, I'd like to know, and you may have answered some of this, what data HRSA already collects on 340B. What data points does HRSA already collect from program participants in the 340B program?
Thank you for the question. Thank you for your leadership on this issue. As I mentioned previously, we are very anxious to work with you on transparency issues, on accountability issues, because at the end of the day, this is a safety net program that is vital to many safety net providers, and we want to make sure that across the system that there's accountability and that resources are going in the appropriate direction. We collect a series of data related to allocations and acquisition. We do some of that through mechanisms that are specific to individual providers, individual manufacturers, and so, but to the extent we have publicly shareable data, we will get that to you.
Great, yeah. If you can commit to providing that list. Does HRSA track the total dollar value of 340B drugs that each covered entity is buying?
We track the total in aggregate.
Okay, in aggregate, but not individually. Am I correct that up until last year, HRSA did not regularly post any sales data on the program?
I'm not sure that I can speak to what happened before last year, but we can get you that answer.
Okay. And it's my understanding that in the past, researchers have had to use FOIA requests to obtain limited sales data showing covered entity purchases at the 340B price, although information on discounts and chargebacks have never been provided when requested. Why is that?
So again, we're really interested in transparency in this program. We have found ourselves to be somewhat limited by some recent Supreme Court decisions related to FOIA issues, but we will be happy to work with you on what we can share.
Yeah, I want to just say I strongly support the 340B program, but we certainly need more transparency. I yield back. I now yield to the gentlelady, Ms. Blunt Rochester, for her 5 minutes.
Thank you, Mr. Chairman, and thank you, Administrator Johnson, for your testimony. Today, we are examining several pieces of legislation to strengthen healthcare access for vulnerable communities and bolster the healthcare workforce. Having served as Delaware's Deputy Secretary of Health and Social Services, our Secretary of Labor, and Head of Personnel, I'm particularly pleased that we are considering H.R. 2411, the National Nursing Workforce Center Act, legislation I am leading with my Republican colleague, Congresswoman Young Kim. This bill will strengthen the nursing workforce and arm states with the tools that they need to implement solutions based on local conditions. Many disciplines in the healthcare sector are facing workforce challenges, but as the largest healthcare profession, nurses are the canary in the coal mine. Just last week, the National Council of State Boards of Nursing released new research showing the impact of the COVID-19 pandemic on the nursing workforce. The report shows that 100,000 registered nurses have left the workforce over the past 2 years due to pandemic-related burnout, and that in total, and almost 1 in 5 of the more than 4.5 million licensed nurses in the U.S. intend to leave before 2027. As the nursing landscape rapidly evolves, stakeholders need up-to-date, actionable information on emerging nursing trends, and this must occur more frequently than once every 4 years. In HRSA's 2021 Health Workforce Strategic Plan, HRSA acknowledges that workforce supply and demand data is not static. The demographics of the nation's population shift over time, as do factors such as labor force participation. And that for data that do exist, data analysis is difficult as the quality and granularity vary widely, and data sources, formats, and occupational definitions are inconsistent. Based on this assessment and what I am seeing in my own community, I believe we need a strategy to not only centralize the study and development of nursing workforce practice and policy, but we also need to better support state-level entities in addressing state-specific nursing workforce challenges. State-based nursing workforce centers who have a consistent mandate and reporting structure to HRSA can help fill this gap. And a core function of nursing workforce centers is to collect and analyze data at the state and local levels, but they can do so much more to support a more resilient, dynamic, and engaged nursing workforce, including training, mentoring, and leadership development. Administrator Johnson, does HRSA's Health Workforce Research Centers program have the authority to fund a nursing-focused research or a technical assistance center? Yes or no?
Thank you so much for the question, Congresswoman. Thank you for your focus on this, and it would be hard to talk about nurses without saying that we owe them an incredible debt of gratitude for what they've done historically and especially what they've done in the last several years, and it shouldn't just be about our gratitude, but it should be in action. And so we really do look forward to working with you on this issue. I think we are working with our lawyers to assess our statutory authority with respect to what we can and can't do under current regulations, and look forward to working.
So the answer is not sure?
Yeah.
Okay, thank you. How might HRSA collaborate with state-based entities, and more specifically, could this collaboration contribute to the stabilization of the nursing workforce in this country?
We think it's really important across all of our workforce analysis to work with states. There are academic centers in many states that are focused on nursing. There are academic centers focused on other parts of the workforce. It doesn't make sense for us to do this work alone or to replicate what's happening in state levels. It should be in collaboration, and that's our goal, and that's what we hope our National Workforce Center is doing.
Great. Thank you, Mr. Chairman. I ask unanimous consent to enter into the record a statement from my dedicated co-lead, Congresswoman Kim, and letters of support from AARP, the Center for American Progress, the National Forum of Nursing Workforce Centers, Health Impact, the American Hospital Association, and the American Healthcare Association. And I want to just quickly shift to the Strengthening Community Care Act, which I'm co-leading with Representatives Joyce, Fletcher, and Stefanik. We are very proud of this bill, and we know it's very important and timely as we reauthorize the National Health Service Corps and the Community Health Center Fund for 5 years. I'm going to go right to my question because I have like 10 seconds. Since most health centers are already providing care related to mental health and substance abuse disorder, as you mentioned, how can us having a requirement improve access to these services and help address the opioid crisis?
Oh, thank you for the question. It is what we are doing, what we can with what we have. We are nowhere meeting demand. And so there is an incredible opportunity here in communities across the country that have been ravaged by the opioid epidemic to leverage the footprint of healthcare services that are already in their community to deliver the kind of substance use disorder services that will get people on a pathway to recovery.
Thank you so much, and thank you, Mr. Chairman. I yield back.
Thank you. I appreciate, without objection, the documents you have requested or submitted. And for the record, we appreciate your work on this. I think you have several pieces of legislation before us today. So I was looking at the list, so this might be the Blunt Rochester hearing today. So thanks for your hard work on these issues. The chair now recognizes Mr. Hudson from North Carolina for 5 minutes.
Thank you, Mr. Chairman. Ms. Johnson, thank you for being here today. And I appreciate your long history of public service. And I also want to acknowledge what a feat it must be to juggle over 90-plus programs. And I really appreciate that and appreciate you being here today. Based on recent reporting, it's my understanding that the Biden administration is launching a $5 billion plus program to accelerate the development of new coronavirus vaccines and treatments dubbed Project NextGen. I would just like to note the committee has not been briefed or received any information on this initiative. So unfortunately, I have to go on what's been reported in the national media. But I'm both concerned and interested to know where the $5 billion came from for this program. Reporting that I've read indicates that, quote, the pot of money, end quote, was financed through money, quote, saved from contracts costing less than originally estimated, end quote. What are these contracts? I specifically asked Secretary Becerra when he was in front of this committee just a few weeks ago about approximately $5 to $6 billion of unexpired, unobligated funding. And the Secretary Becerra claimed this funding was, in fact, committed and, again, quote, in the pipeline to be signed on the dotted line, end quote. Was he referring to Project NextGen? I've also heard from my appropriation colleagues this funding came from the Provider Relief Fund and the American Rescue Plan funding and was intended for testing. Administrator Johnson, can you please provide any clarity on this? Was any amount of funding intended for HRSA Provider Relief Fund reallocated to the recently announced Project NextGen?
Thank you for the question, sir. I can't speak to the particulars of the NextGen project. I don't know the details there and would refer you to our Department of Budget experts on that question. I will say that as we get to the end of the Provider Relief Fund allocations, there are some instances where there are resources that we might have held for applications or for reviews of reconsiderations where reconsideration applications came in less than we anticipated. So there are resources that are available through the Provider Relief Fund.
But to your knowledge, have those been transferred to this new project next gen?
I believe that, again, the Budget Office will be able to answer that for you more directly. I don't know that resources have to be transferred for that purpose, so.
Okay. And then you talked a little bit about some of these unobligated funds or unspent funds. Can you please speak to any contracts that you're aware of that, quote, cost less than originally estimated or were used to subsidize this new project? Are there any specific?
I'm sorry, I don't know the details. I don't know what that is referring to.
Well, could you get back to us if you talk to your budget folks about funds that are transferred to project next
I'm
gen?
happy to talk to the budget team and ask them to, and raise the questions that you've asked.
I mean, honestly, they'll probably respond to you quicker than they'd respond to me. So
Well,
if you could get back to us on that, I would really appreciate it.
Thank you, sir.
And then in your written testimony, just shifting gears here, I appreciate you mentioned the importance of assistance to rural communities. I represent a rural community, and I work very closely with our community health centers, and they do a tremendous job. And during a recent visit to one of these, Moncure Community Health Center, I saw the need for more flexibility, like the legislation that came out of this committee that authored the Mobile Health Care Act, which allows them to use those funds in rural and underserved communities for things like mobile health units. We've had a lot of success with those. We've been able to provide mental health access to schools that normally wouldn't have access to mental health. As you know, that's a real crisis right now. So, anything we can do to continue to offer flexibility to these rural community health centers, I would encourage you. But that's been a real success story. And then Representative Pallone mentioned another critical need in healthcare today. I hear everywhere I go is workforce. And, throwing money at a solution is not always the best, or a problem is not always the best solution. We've had some success in North Carolina. Numerous community health centers have formed partnerships with the University of North Carolina, as well as Meharry and HBCU to provide workforce. One huge success story also has been increased training resources and furthering wellness activities in Randolph County, North Carolina, resulting in decreased costs for employee health insurance over the past 3 years. These kind of partnerships, this kind of innovation is really showing results. So I would just encourage you, any way that HRSA can help encourage this kind of innovation and this kind of creativity, it is working. So we'd love to see more of it.
I very much appreciate that. Thank you. We actually fund Meharry through a host of our discretionary programs on workforce training, so I'm really pleased to hear that you've seen these programs in action.
Great. Thank you. Mr. Chairman, I yield back.
Thank you. The gentleman yields back. The chair recognizes Ms. Barragan from California for 5 minutes for questions.
Well, thank you. Thank you, Mr. Chairman, for having this important hearing. Administrator Johnson, our nation faces a healthcare worker shortage. Just last week in my congressional district, I met with one of my hospitals who was telling me about the worker shortage and the impact it's having. So the worker shortage and the dental sector is not exempt from these workforce challenges currently being discussed. The shortage of dental providers impacts patients' access to oral health care across the country. In fact, research by the ADA's Health Policy Institute indicates that 1 in 3 dentists do not have full appointment schedules because of staffing issues. What is HRSA doing to address the dental industry workforce shortages, particularly with respect to dental hygienists? And does HRSA have plans to reopen any of the oral health training programs, such as the state oral health workforce program?
Thank you for the question and for highlighting what is a critical need. Far too often, oral health gets overlooked when we talk about critical healthcare issues, and it is essential to overall health and is a place where we need to make sure that there are providers in underserved and rural communities. We, dentists and dental hygienists are part of the National Health Service Corps. Dentistry is also an eligible discipline in the Teaching Health Center GME program, so we are training dentists directly, and we are supporting loan repayment for dentists to get into the communities in need. And as you mentioned, we have our discretionary programs as well, and we are in that regard limited by appropriations, and so we will do what appropriations resources allow us to do in that regard.
Great, thank you. In January, the Giger-Gibson Project on Community Health at George Washington University noted the potential effect of the Medicaid unwinding on community health centers, stating that the Medicaid unwinding is expected to have significant ramifications for community health centers. The unwinding is estimated to decrease total health center revenue with an associated loss in patient capability of 1.2 to 2 million patients and a staffing capacity loss of 10 to 18.5 thousand staff members. Medicaid is a critical funding source for community health centers. Medicaid's really important in my congressional district, very working class. And I'm concerned that the loss of Medicaid coverage for millions of patients will decrease the ability of health centers to serve all of the patients who need care, not to mention the number of Latinos. As a chair of the Congressional Hispanic Caucus, I'm concerned about the amount of Latinos that may lose coverage. How does HRSA plan to help community health centers as the Medicaid population is expected to decrease, and is there more Congress can do to help?
Well, thank you for raising it. We share your concern. It is vitally important that people who remain Medicaid eligible don't lose Medicaid coverage for some paperwork or bureaucratic reason because they don't get the right paperwork or don't know to respond. That's why we're really focused on making sure all of our enrollment assisters, all of the ways that we can partner with health centers and with other community organizations, our other grantees, to get the word out to people that these reviews are coming and they need to be able to respond to them, and to support people in that is critical. But there are going to be people who are transitioning off of coverage, so we want to also make sure that they get into marketplace coverage as quickly as possible. That matters not just for those individuals and their families, but for the fiscal viability of the health centers that we're talking about here today. And so that's why it's so important that we work together on the continuation of mandatory funding for these providers.
Great, thank you. My last question is just a really general question. When I had my meeting last week with Long Beach Memorial about the worker shortage issue, I have a sister who's a nurse too. You hear firsthand the stories of how challenging it is for those in the field. You know, what can we be doing? I know that there is, the children's, medical education training program and the adult version of that, and I know there's a huge disparity in funding there. We know that there's nursing shortage bills, but what would you be your suggestion on how to best address this?
The workforce issues writ large?
Yeah, the shortages that we're having.
The path we've laid out in the president's budget is sustaining the commitment we've made to National Service Corps at the level we've made it over the next 3 years. Training more nurses by solving some of the bottleneck issues that make it harder for people to get into nursing because we don't have enough faculty. Training more mental health and substance use providers through our existing programs. Our budget proposal would allow us to train 18,000 new providers. And ensuring that we create our healthcare workforce innovation program to develop new models for more rapidly training people to get into the workforce.
Thank you. We also need to make sure that people can afford to go to nursing school, student loan debt relief, and other programs of the nature. Thank you, and I yield back.
Thank you. The gentlelady yields back. The chair now recognizes Dr. Joyce from Pennsylvania for 5 minutes for questions.
Thank you for yielding, Chairman Guthrie, and thank you for holding this important hearing. One of the most consistent issues that I've heard in my district in Pennsylvania is the shortage of physician and healthcare workers and barriers to access to primary care. For this reason, last week I introduced H.R. 2559, the Strengthening Community Care Act, with Chairwoman Stefanik, Representative Blunt Rochester, and Representative Fletcher. And I would further like to thank Representatives Carter, Bilirakis, DeGette, and Spanberger for their support of this measure. This critical piece of legislation would provide for community health centers across the country, including centers in my own district, like Keystone Rural Health Center, Broad Top Area Medical Center, and Hindman Area Health Center, which helps serve the needs of over 250,000 individuals, patients, in Pennsylvania's 13th district. This bill will also reauthorize the National Health Service Corps, which supports more than 20,000 primary care medical, dental, and behavioral health providers through scholarships and loan repayment programs. I, like many on this panel, have heard from communities throughout my district about the need for expanded access to behavioral health care and substance use disorder treatment, and community health centers play an incredibly valuable role in providing mental and behavioral health care to vulnerable populations. Administrator Johnson, what percentage of CHCs provide these specifically behavioral health services in communities today in America?
Yeah, thank you for the question. I think most health centers try to provide some level of mental health services. but it's a significantly smaller percentage. We can get to the particulars on substance use disorder. What we know is that even when they do, they can only meet about a quarter of the demand for mental health services and about 6% of the demand for substance use disorder services.
Thank you. And how important is the stable and sustainable federal funding in the Strengthening Community Care Act to our health centers' ability to continue to provide this access to behavioral health care?
Yeah, thank you. I don't know that I've seen the particulars of the bill. I will say writ large, sustainable, predictable funding makes an incredible difference to retaining the health workforce, to delivering services in the community, to planning for what you can do going forward, to surging to meet critical health needs.
Again, I thank you. How do community health centers typically comply with the requirement to provide emergency services and ensure continuity in primary care services that a patient should receive?
So community health centers are required and closely monitored by us to ensure that they have in place all of either directly or contracted relationships that allow them to comply with all of the Section 330 requirements.
And on an additional matter, we're hearing from community health centers and other providers who rely on 340B that large PBMs are pickpocketing their 340B savings through predatory contracts and without sharing any of the savings with their patients. There's been plenty of talk about the need for more transparency on how 340B is being used. You mentioned earlier in the discussion here today that you collect specific data at HRSA. But on this matter specifically, can you speak to whether HRSA can address these issues through the existing authority, or does it need Congress to intervene?
I believe, Congressman, that we would benefit from your assistance in this regard because we are continually reaching roadblocks when it comes to our authority. So we would benefit from working with you on this topic.
And I agree with you. It is time for Congress to intervene and stop those roadblocks from occurring. Once again, I thank you for being here today. And Mr. Chairman, I yield the remainder of my time.
Thank you.
Gentleman yields. Chair now recognizes himself for 5 minutes for questions. Ms. Johnson, thank you for being here. Appreciate this. Very important. Obviously, what you do and this agency is extremely important. I, too, want to chime in, as I know some of my colleagues have already, about the 340B program, because as the oldest pharmacist in Congress, I'm very concerned about it, and I'm very concerned because of my FQHCs and because of the hospitals, the rural hospitals. I represent the entire coast of Georgia and a lot of South Georgia. As we like to say in Georgia, there are two Georgias, there are Atlanta and everywhere else, and I represent everywhere else, and a lot of that is rural areas, and certainly the rural hospitals depend on this program. And they've been very concerned about what has happened with some of these manufacturers who are refusing to participate, and quite honestly, I can't blame them. I think the program needs guardrails. It does not need to be eliminated. It needs to go back to what it was intended to be, what it was intended to serve, and the population that it was intended to serve. Unfortunately, as has been pointed out, there are a lot of hospitals, or a lot of healthcare systems that unfortunately are not using it and utilizing it the way that it should be. So, having said that, I know that there was a report by the New York Times, the Wall Street Journal, and other outlets by investigative journalists that some of the nonprofit hospitals are doing exactly that, and that is that some of the dish hospitals are using the program to pad their profits without regard to the needs of the vulnerable patients. And the second thing that I want to point out is, of course, the PBMs, and I'm no fan of the PBMs, as I'm sure you know, but they're getting into the 340B program, and it doesn't surprise me one bit that they are, but they're stealing discounts that were intended for the patients. Both of these issues need to be addressed. Both of them need to be addressed, and just as my colleague, Dr. Joyce, just mentioned, we want to help in legislatively if we need to, and as you indicated, it appears that we need to. So let us help you. There's been suggestions of starting a 340C program. I'm sure you've heard of that, just to quantify and to specifically identify who this program is to be for. Now, I'm not suggesting that all dish hospitals are abusing the program.
are pushing the envelope on the program, if you will. But there are those that are doing that, and particularly in the oncology practices, particularly with cancer patients, and that's a big concern as well. Some of these healthcare systems are buying out oncology practices for no other reason except to utilize the 340B program. And that's not what was intended for. You know that as well as anyone. So again, we stand ready to help you with any kind of legislation that you need. Specifically, what is the agency doing to curb these abuses? I know we've got a couple of lawsuits that are out there right now, and we're expecting to hear the results of some of them hopefully soon.
Yeah, thank you for raising the issue. We have been taking actions such as, where we've seen manufacturers not selling to covered entities via their contract pharmacy arrangements, we have sent violation letters to manufacturers in that instance. That is the source of a considerable amount of litigation, and our authority is being challenged in that regard. We also recently sent a series of letters just to covered entities as part of our ongoing compliance work with questions concerning their use of, their compliance with covered entity requirements. We are working to use all the tools that we have. We recognize that we would benefit from additional tools here because we share the goal of accountability in this program. Like you, we recognize there is a critical role for 340B for safety net providers in community, across community. It makes a real difference. But we also want to make sure that there's accountability.
Good. Very quickly, with what little time I have left, community health centers have been successful in expanding access to affordable and quality health care all throughout my district, and I'm very proud of that. Last year, I was proud to support the Mobile Health Care Act that gave community health centers the flexibility to use federal funding and establish new mobile unit delivery sites, and many of them have done that to the benefit of a lot of people in our rural areas. So how will the additional flexibility around the new access points funding support mobile health units and community health centers' ability to reach more underserved communities and patients, which is what we want them to do?
Yeah, I mean, the provisions in our budget that are really about trying to do more access points is because what we hear from community health centers again and again is we could better reach the population who needs us most if we had a little more startup resource to get into a few more communities. And that's why we included that in the budget.
Good. Thank you very much again for being here today. My time has expired, and at this time I'm going to recognize the gentlelady from Washington, Dr. Schreier, for her 5 minutes.
Thank you, Mr. Chairman. And thank you, Administrator Johnson, for coming today to speak on these critical programs that strengthen our healthcare provider pipeline and bolster our healthcare workforce. First, let me just say about the special diabetes program. I have type 1 diabetes, and I just want to thank Representatives Dingell, Bilirakis, Ruiz, and Cole for their work to reauthorize the special diabetes program and the special diabetes program for Indians. They're vital programs that can help ensure progress on predicting and delaying, treating, possibly curing one day with an artificial pancreas, something that I have been hoping for 38 years now. These programs are also critical to helping patients manage diabetes and complications, and I'm extremely supportive and look forward to their passage. Second, I want to highlight, as some of my colleagues already have, the shortage of providers in the U.S., and we're feeling this most acutely in rural areas and underserved areas. But we saw early retirements and really mass resignations, much of that related to the pandemic. So we need a bigger pipeline and a faster pipeline for new providers, and we also need ways to incentivize those providers to practice in rural communities, like parts of my district, and in underserved communities. What I have heard in some of the community health centers in my district, like Health Point, for example, they have highlighted the importance of stable and consistent funding for teaching health center graduate medical education. In fact, some of the residents who I met were pretty anxious that the funding for their program might dry up before they finished their 3-year residency program. So Administrator Johnson,
Ranking Member Pallone noted the importance of sustained and stable funding for these programs, along with several of my colleagues. Can you talk about why stability of funding is so important for community health centers and graduate medical education to continue to generate providers in rural areas?
Thank you so much for the question. We ask a lot of community health centers, and then we ask a lot of residents who come to train in community health centers. We want them to manage people who have complex health conditions, who lead complex lives, and ensure that they have a usual source of care and are available to them as readily as possible so that they are as healthy as possible, and we're keeping people out of emergency rooms, and we're getting them primary care. All of that is challenging work on a good day. When the source of your funding is uncertain and variable and not guaranteed for the full life of your time in residency or for the full life of your budget planning as the head of a health center, that is very distressing and hard for us to recruit residents. It's hard for us to retain leadership in health centers. It's hard for our health centers to recruit staff. All of that is difficult without sustainability and without really understanding the growth path that we know health centers need to be able to continue to meet demand by having extended hours, by having more sites.
Thank you. I don't recall when I graduated from medical school having these rural opportunities, distant opportunities, or even having to think about whether a residency program that I chose to start would have funding all the way through. And so I can understand that anxiety. You know, I also wanted to highlight some of the work being done on the ground in Washington State by our community health centers and teaching health centers. Both Columbia Valley Community Health, CVCH, and Community Health of Central Washington offer these rural residency training programs. In fact, Washington State University's medical school has been a big driver of this. I was wondering if you could talk specifically about rural residency programs and why they're so important for maintaining a workforce in rural communities.
Yeah, it's hard to start up a residency program. It takes a lot of work. It takes getting accredited. It takes having the staff and the faculty, and it takes recruiting a strong faculty and a good curriculum and all of that work. That is hard to do in a rural area if you don't have some support. And so our Office of Rural Health Policy is able to support the development of rural residency programs to get them on the path so that then they can come into other GME programs. And it makes a huge difference in communities across the country.
Thank you. We talked about see one, do one, and teach one, and this is reminding me of that. Go to a rural area, train there, stay there, teach the next generation of rural providers. So thank you very much. I'm out of time. I yield back.
Thank you.
Gentlelady is yielded. Chair now recognizes the youngest pharmacist in Congress, the gentlelady from Tennessee, Ms. Harshbarger, for 5 minutes.
Thank you, Mr. Chair. And thank you, Administrator Johnson. You know, I represent a rural district in East Tennessee, and I believe your agency reports that more than 80% of rural counties in the U.S. are considered medically underserved. Does that sound about right? 80%?
I would have to validate that for you, but I agree with you.
But I've seen statistics that only 1/3 of NHSC placements are in rural communities, and after they complete a typical 2-year commitment, too many of those members leave for higher paying jobs. In part, to continue paying down their school debt, for example. And I guess my question to you is, what can we do to ensure that the NHSC adequately serves the country's rural medically underserved areas?
Thanks for the question, because this is a great part of the National Health Service Corps that's not totally as well understood, which is we will further incentivize you after you complete your first obligation with us. We will give you a continuation and continue to help pay down more of your debt if you stay in the community you're in. So I actually just visited a site in a rural community where we had people who'd been there for more than the 2-year service commitment, because we were as long as they had eligible debt, we were continuing to help them pay down. And they were starting a family, they were gonna live there because that's where they were.
We want them to. You know, we need to look at innovative solutions to keep these physicians in the area. And I helped introduce a bipartisan Rural American Health Corps Act with David Kustoff here in the House and Senator Blackburn in the Senate.
And I just recommend my colleagues sign on to that legislation, and it's sort of a sister program to NHSC. And it helps with loan repayment in a lot of ways. So, and I'd love to work with you for technical feedback on that bill.
We would be delighted to do that. Thank you.
Absolutely. But I do want to talk about, yesterday, the administration announced a $1.1 billion program to continue to provide COVID-19 vaccines and therapeutics to underserved Americans, the HHS Bridge Access Program. And it's my understanding that $1.1 billion to fund this program was pulled from the Provider Relief Fund. And what I want you to do, can you confirm that that $1.1 billion came from the HRSA Provider Relief Fund for this new unrelated program?
We had previously been funding supports and services for individuals who were uninsured. And as vaccines and therapeutics transition to commercialization, it has been recognized that it'll be very important that we are reaching underserved communities and uninsured communities. And so as an allowable use of provider relief funds are being used to support
So
uninsured
is that, will that program end in December of 2024?
I believe that's accurate.
Okay. I guess my question is, how did you come to that specific $1.1 billion number that you need between now and next December?
Yeah, I believe that, and again, I would need to consult with our colleagues across the department who helped design the program, but I believe it was looking at where uninsured needs are and where we thought, because of the cost associated with administration of these vaccines and therapeutics, what that would look like.
Okay, that brings me to another question. Was there an assumption that annual boosters would be recommended and incorporated into that $1.1 billion?
I don't know the answer to that question, but I'm happy to get back to you on
If
that.
you could find that. Because I guess I'm asking that because assumptions were made around anticipated demand, and there's clearly been a decrease in COVID-19 vaccine uptake. So, you know, that's just my question. How did you get to that $1.1 billion? But if you could do that, that would be fantastic.
Thank you.
And I know I've got a minute left. I wanted to talk about countermeasures injury compensation program. And I thank you for your recent response to the congressional letter that was sent by our colleague, Rich McCormick of Georgia, and a lot of the colleagues here signed on to that. In our letter, we expressed concerns over the delays that are being experienced by individuals making claims under the CICP and sought information regarding how your agency intends to address the barriers to compensation reported by our constituents. My question is, how many reviewers are being used for the nearly 12,000 COVID vaccine injury claims on file?
I believe we've done a series of hiring because we have recognized the need to grow this program, which, you know, historically, for the 10 years it had been around, had only gotten 500 claims over the life of the program.
Yeah.
So we have scaled up
more now.
hiring.
Yeah.
And I believe we're at 38 now.
38. How's the CICP prioritizing these claims? And in particular, is there any focus on death claims?
We are, I will need to get back to you on the particulars of that. Yeah.
Yeah, well, I got other questions, but I'll submit them to you. And with that, thank you for being here, and I yield back.
Gentlelady yields back. Chair now recognizes Gentlelady from Iowa, Dr. Miller Meigs.
Thank you very much, Chair Carter, and I thank the committee for having this hearing. So let me first say that I'm a physician as well as a former director of the Iowa Department of Public Health, so very familiar with health professional shortage areas, HPSA, our maternal child health grants. But I just want to say that workforce is a complicated issue, and it's complicated because when you're looking at physician workforce especially, people just don't locate where reimbursement is the highest. And let me just say that in our small community of 26,000 people, we had a very vibrant medical community, and I'm fully supportive of our FQHC, but our FQHC also decimated our provider community. Our FQHC does not pay property tax, which put an increased burden on the private practices that got displaced, which were paying property taxes. Who pays for electronic health records when you have to institute that, or electronic billing, or all of the other mandates that individual practices have had. And so you have had, from the start and the inception of the Affordable Care Act, 50% of physician practices were independent or a small group, meaning not consolidated, and now only 20% of those practices. So the majority of physicians are now
either hospital employees or large group employees. With that, noticing in your testimony, you had mentioned that you had reached a milestone of 20,000 family medicine providers, pediatricians, obstetrician, I won't go through the entire list. That was a historic high. So is that 20,000 people that are in practice now, or is that 20,000 people over the 50 years?
That's 20,000 people who are in the field today.
Okay. You also mentioned that you have a retention rate of 2 years beyond the service obligation. What's the current service obligation in the National Health Service Corps?
The service obligation is 2 years for the first award, and then the options for continuations, depending on allowable.
And what's an award?
$50,000.
So 2 years for each $50,000 in
2
loan
years for the first $50,000, that's right.
of loan repayment.
Loan repayment.
Okay. And so what's the total cost of the program?
The total appropriation for the National Service Corps today, this year, we're at $417 million.
And what's your overhead cost, i.e. how much of that money goes out to loan repayment and how much of that stays within the institution?
I don't know the answer to that off the
Could
top
you
of my
get
head.
me the answer to that?
Absolutely.
And so, and what is the retention rate beyond 2 years? Because I can tell you what the retention rate is on our J-1 visa programs beyond the 3 years of obligation.
Beyond the 2 years, the first 2 years beyond the 2 years of obligation, our retention rate is 86% from our.
How many stay beyond, so after 2 years, so like for 5 years, what's the retention rate?
What I can tell you is after the completion rate of 2 years, the 2 years that followed, at the end of the 2 years that follow that, the retention rate is 86%.
Okay. Thank you for clarifying that. Are you also aware of, in the National Residency Matching Program, have you looked at the stats on matching rates for family practice and emergency medicine?
We keep abreast, our team keeps abreast of matching rates.
Okay, and so is the matching rate 100% for family practice?
I don't know the answer to that.
The answer to that's no, and you just told me that you keep track of those.
Our team keeps a track of that, that's
Okay.
correct.
So the matching rate for family practice, we do not fill the number of slots that are available. And if you look at a university academic medical center, their slots will be 100% filled. Those at a training health center are not 100% filled. So when we're talking about increasing providers, what is it that we can do to increase or narrow that delta between the number of slots that are available and the number of unfilled positions? And 25% of those positions are currently filled by foreign medical graduates, which I think is great.
It's critically important that we have as much lead time on recruitment, and so that's why we think stability in the program is really important, because it's hard to recruit. You know this better than I do. It's hard to recruit.
Well, the delta has been increasing. So I can send that data to you. I should have put up a graph.
No, but
the delta's increasing. So from, even from 2013, prior to the pandemic, there has always been a gap between the number of programs offered and the fill rate. That delta has been increasing. Certainly a little bit exacerbated by the pandemic, but it was also fairly significant before the pandemic.
Yeah, there have always been challenges with the fact that the funds have to be renewed. And early on in the program, there were challenges with the stability of the fact that the dollars were allocated on the fiscal year, not the academic year.
Thank you for that. I would say to investigate that more. My last question is, as a physician, I practice. I see patients on weekend. I see patients at night when I'm practicing. So why do we have to have $250 million investment to extend office hours? I would just say you have to have evening and weekend office hours. As a federal government, if we're subsidizing an FQHC, a training health center, a community health center, I would make that part of that program is that they have extended office hours in order to be able to adapt to and respond to their patient consumer demand. Thank you. I yield back.
The gentlelady is yielded back. The chair now recognizes the gentleman from Texas, Mr. Crenshaw, for 5 minutes.
Does that mean I can schedule an eye appointment with you? I didn't know that. All right.
I would see you.
I need a checkup.
I drive you to your.
I got issues. All right. Thank you for being here.
Look, when we evaluate these programs, I agree with my colleague here about the need to use our money wisely. We have to assess how effective the money is that we're spending. So I want to drill down on a couple policies, make sure we're actually strengthening our access to care and continuity of care. Many of the programs we're talking about today are meant to advance primary care. That's a big passion of mine. I think that's where any patient enters the healthcare system, so that's where legislatively we should enter healthcare reform. And look, I think there's a few opportunities that we could look at here to make this better. Inflation, soaring workforce costs, that has caused a lot of problems. It means it's really hard to recruit health professionals and retain them. This is particularly true for community health centers. So I'd like to submit a statement from Lone Star Family Health Center, which serves thousands of people in my district, to show that these workforce challenges are real for them as well. Community health centers are supposed to improve access to primary care services that can reduce costs to public insurance programs while also preventing emergency room visits that are extremely costly. So that's the value add that we're looking for. But when you can't hire anyone, and we're not just talking about physicians here, we're talking about dental hygienists, we're talking about medical assistants, it becomes pretty difficult to provide that care. So I've supported legislation to remove unnecessary red tape for licensing medical professionals. Can you comment on this in general terms? What do you need to help us hire more people, make it easier to hire more people? What are the barriers that we need to overcome?
Thanks for the question. One of the things that we've been working on lately is ensuring that we are linking some of our grant dollars to apprenticeship programs so that we're not just training, but we're training and doing on-the-job training as well so that we can prepare people for that first step in the health professions career ladder and then really working to bring people up the career ladder as we move people into the healthcare workforce. We also, in our budget this year, have a new proposed initiative that we call our Healthcare Workforce Innovation Proposal, which is really about addressing some of the key barriers, getting ideas and new innovative ways to do healthcare training and to try to scale what works best.
Is it you're trying to reform training? Can you be more specific? I'm curious about that.
So I think that what we hear from some places is maybe the training period is longer than it needs to be,
Okay.
or maybe we could do some things creatively to match people differently, those kind of things.
Okay, that's good. Licensing reform, any thoughts on that?
We through some of our telehealth work, we've actually been working on the compacts that states use in health professions to ensure that providers can work across state lines. We're really interested in ways to encourage those kind of best practices.
Okay, I think you'd like the bill that we're supporting that. I hope we could pass that. As you know, National Health Service Corps is supposed to be a deal where physicians receive scholarships and loan repayment in exchange for practicing in at-need communities. But a recent study prepared for the Department of Health and Human Services suggests clinicians who don't participate in that, without those benefits, actually practice in health professional shortage areas more often and for longer than those who do. So that tells me we might be wasting money on some of these folks. There was an average 13% gap between non-program providers and participating providers. That's just strange. So how long, I have a couple of questions. How long does the average National Health Service Corps participant practice in a shortage area after their obligation is complete? I think I'm repeating these questions, but I was...
Yeah. And so there is their base obligation to stay in the service. They have a service obligation to stay for 2 years. If they get a continuation, sometimes they stay for multiple years. And our data is where we look 2 years after they complete their service obligation, 86% of people are still in underserved communities.
Okay, there's obviously some kind of problem here, isn't there? So are we not using this money correctly? Is there better ways to incentivize? Are we exploring better ways to incentivize practitioners in those underserved
We're
areas?
always looking for ways to continue to grow the workforce in the communities that need them the most, which is why we also have the Teaching Health Center program, which is about not just, loan repayment is about getting people there who are already through residency. Teaching Health Center is actually about doing the residency in the community where you want people to practice. And then we also have National Health Center scholarship programs where people make the commitment and as part of their medical school education.
Okay, well, I'm out of time. Thank you. I yield back.
The gentleman yields back.
believe that is all the witnesses. I ask unanimous consent to insert in the record the documents included on the staff hearing documents list. Without objection, that will be the order. I remind members that they have 10 business days to submit questions for the record, and I ask the witnesses to respond to the questions promptly. Members should submit their questions by the close of business on May 3rd. Ms. Johnson, thank you for being here. Appreciate it and appreciate the work that your committee, your agency does. Without objection, the subcommittee is adjourned.